Okay, shall I stand out? Are you not going to sit down? Okay. Morning. Okay, so. Morning, everyone. Bonjour. Buenos dias. Hello to everyone online. Are we online as well? Good morning, everyone. Thank you for coming back. And we have a very full and exciting day again today with some wonderful panelists. But just to pick up on some of the great things and very inspiring discussions yesterday, we had what a lot of people said is that they really appreciated the frank and open discussions between partners and countries, because that's also how you get things moving forward. So thank you everyone for that. We heard a lot about the issues around fragmentation and silos, over-reporting burden, but we also heard about some opportunities and some of the things that are working well. But a lot of it was about the country needs, challenges and opportunities, and especially around data governance and why it's important to move forward for action. Also that, everyone liked the quote, data is the new oil. So I think that's going to be a favorite quote moving forward for many. And also the importance of, this morning, we're going to be looking at the importance of, investment in health information systems. We're going to look at the next steps for advocacy and feedback, how we can better support countries, better data for governance, health information systems, and getting all your input on how to make this actionable and really working moving forward. We're going to have this afternoon a partner roundtable with 15 partners who are going to reflect back on what we heard, especially from countries, and how we can make it happen moving forward. And then the Secretariat is going to then, having heard all of this, they're going to come forward with some proposals also to get your feedback so that we can really move forward and turn all these great ideas into action. Because one of the other quotes that we heard, which people seem to pick up a lot on, is that there's some very practical needs versus a lot of the principles on paper. And that, not one size fits all, that we need to listen and also not throw out some of the good work that's been done, but it's really got to be consolidated so that it makes sense moving forward. And also there's a lot of choice out there. Countries need help on human resources. Also, there's the technical side, the infrastructure side, and not forgetting that there's often a divide, as we heard on the data tree, from what the people in the action out there, and then the background of what's going on a technical and infrastructure level. Health data and investing in data. So please also, if you're online, we really welcome your input, your comments. We have some, also I think we're going to be hearing from Togo and a couple of other countries maybe online. So we look forward to your input, and please send your comments, and also remember to tweet, because now's the time to really get these ideas out there so the people who didn't have the opportunity to participate, that they can actually also join in on the online discussion and moving forward. So thank you very much. Without further ado, we won't do a stretch this morning because you've all walked here, but we will at lunch break. We're going to have you all doing your move and stretching again. So meanwhile, we're going to listen to the panel. Okay, so without further ado, we now have the panel on strategies to strengthen health information systems in countries. And we're going to start like we did with yesterday with, let me just check I've got the right thing so I don't make a mistake. So we have got it. This is the better data for better health. Oh, the video. Sorry, the video. Thank you. Great. From Botswana on the power of the data journey.
Data is very powerful and it's very important into our district or into a national level.
We are able to understand and know how many of our clients need assistance. We're able to understand the burden in the district.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. we wouldn't be able to plan.
It influences the partnerships, how they would help the district, how can they help at national level.
So in this here office, that's basically where most of our reports come in from various health facilities on a monthly basis. As the reports come in, we track which report has been brought. We check if the information within the report is correct, if the information within the report is completed.
This data comes as raw. When it is compiled now, it becomes a district report.
Once that is done, the ministry at the headquarters, the coordinators of those various programs are able to track and see the pattern or the numbers that we capture within the DHIS.
Part of what we do is, with this data, we do our reports. So that informs us of where we are, what we are doing. Are we meeting our targets? Are we still doing what we said we were going to be doing?
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients do we have. This really helps us to make a case for provision of services, especially some of our clients are out in catchment areas. We are able to understand where to take our services to.
Without the facilities collecting that data and reporting to us, we'll never have an idea of what is happening in the field. Then we are able to react based on the data reported. Hence, I'm saying what data is very important as far as decision making is concerned.
It helps in that when I refer a client to the next service provider, I already give that service provider information. So the client doesn't have to go there and repeat what they have said to me, and it saves them their dignity, and it gives them, you know, kind of some power to say at least, and also to reassure them that we are interested not just in their story, but we are interested in giving them service that will help them go through what they are going through.
Great. Thank you for that video from Botswana. And now we're going to hand over to Claire Melamed, who you know from yesterday, who's the Chief Executive Officer of the Global Partnership for Sustainable Development Data, who's going to speak about investing in data for SDGs, data with purpose and an investment case.
Thank you. Is this microphone working? Sounds quite good. Okay, thank you. And a very good morning to everyone. I hope you had a good evening. For those who weren't here yesterday or who've forgotten, my name is Claire Melamed. I'm the CEO, as Samantha just said, of the Global Partnership for Sustainable Development Data. We're very enthusiastic members of the Health Data Collaborative and feel very comfortable in the collaborative, because what we do is essentially try to replicate this sort of approach across all of the Sustainable Development Goals. Our mandate is to, exactly as the collaborative does, to work informed by the priorities and the perspectives of our partner countries. We work with about 20 or 30 governments around the world, mainly in Africa and Latin America. And our role is to broker partnerships between parts of government and some of the external actors who have critical technologies, resources, knowledge and information to help improve data systems. So yesterday we heard a lot, and I thought, you know, it was incredibly interesting perspectives, and the partner panel in particular, I learned a huge amount. And what I was really struck by listening to you was how closely the experiences and the challenges of the health sector mirror every other sector that we work in. And we heard a lot about the importance of data, of course, and this is an audience that needs absolutely no reminding of that, the importance of data in solving challenges, in kind of the sort of granular level service delivery that really affects people's lives that we just saw in that video. But we also heard a lot about the challenges and about the lack of capacity, about the lack of some of the technology and infrastructure, and particularly the lack of political leadership, which really is the key to unlocking all the other problems in a country. And I remember a colleague from Botswana talking very powerfully about that yesterday. And I think what I really want to talk to you about today is about some of the opportunities of this year, the political opportunities and the momentum which is building to help us to begin at least to set a trajectory to overcome some of those challenges. As those of you who are closely involved in specifically the SDG monitoring and reporting know, of course, 2023 is the midpoint of the Sustainable Development Goals. So in the UN system and those who support the SDGs, data is going to be in the spotlight this year in a way that perhaps it hasn't for the last few years. We saw that very clearly in the most recent UN SDG progress report that really, again, foregrounded the challenges created by the lack of data. The fact that, for example, just to take one example from that report, there are only 6 of the 17 SDGs for which more than 2/3 of countries have data to report. And the gaps, the critical gaps in SDG data, which are impeding at least our ability to monitor the goals, let alone actually achieve them, are really persistent and difficult to overcome. We do have this year, though, the opportunity not just of that SDG midpoint and the attention and focus that comes from that. Also, the G20, the data for development is squarely on the G20 agenda in a way that it hasn't ever been before. The Indian presidency have put data for development as one of the key areas in their in the development working group of the G20. This is a sort of an opportunity that we haven't seen before. And we also have the Africa Climate Summit coming up in September, hosted by Kenya, who's been one of the leaders across, not just across Africa, but globally, on data for development and really embracing the possibilities of new technology. And they're hoping to unveil some new partnerships at the Africa Climate Summit that can really help to show the way to a new generation of data partnerships to help accelerate progress on climate and the SDGs. So we have a number of political opportunities and moments coming together in 2023. I'm already talking to several of your institutions in the room about this. So for some of you, this is old news, but I think it really helps. I think for a long time, us in the data space have really felt somewhat boxed into the sort of technical arena that we find ourselves and have been wanting to reach out politically and really make the case to political leaders. And I hope that this is the moment that we're going to be able to do that. So in order to support this advocacy, my organization, working closely with the World Bank, Mala's colleagues at the World Bank, and also with the UN leadership, decided that the first thing we needed to do was to do some research to really start to quantify what is it that we mean when we talk about the importance of data and the progress and the way that data can help to accelerate progress. I think the first thing to stress here, though, is that we're talking throughout about data systems. We heard again really powerfully yesterday about the challenges of fragmentation, about how if we approach data in a piecemeal way and think that we can solve the problem just by investing in one survey or one project over here or one new platform, we're really not actually tackling the fundamental challenges around systems that can deliver across a range of sectors in a timely way, in a way which is inclusive of the whole population of a country. So the focus here is very much on making the case for systems across the board. That, of course, includes health, but many of the things that we talked about yesterday about administrative data systems, the importance of foundational data are critical for health, but pay off across other sectors too, across education, across agriculture, across all kinds of areas of government policy. So when we're talking about systems, we're talking about a government-led data system, which is often rooted in an independent statistics office, but clearly, where all of the delivery ministries, health, agriculture, environment have a very strong interest in making sure that across government, there is a system which is delivering for all, which is politically supported, which is empowered to produce data, whether or not it's giving governments the answers they want to hear, and which is well funded. And of course, you know, during COVID, I think the importance of having a system in place that could deliver at speed, at scale, across a whole range of different areas was brought home like never before. And that's been true across a range of disasters in Bangladesh, for example. The UN found in some of the recent climate emergencies that having a system in place that could deliver early warning data that could anticipate crises meant that the cost of responding to disasters was halved with good data, and with a good data system in place before that could anticipate crises, that could get help to people before they were desperate and before it became harder and harder to deliver. So with this, we work with Dolberg advisors to help to do the research, and found that when you look across a range of studies and you look at quantitatively, what is it? How important is data systems? What is the value for money case of investing in data? And what are the different ways that data can deliver results, can deliver value for money across the board in different sectors? When we looked at all of the available evidence, we found that across the existing studies, and these cover different sectors, different countries, the rate of return on $1 of data. So if you invest $1 in a data system, the rate of return varied between $7 back and $73 back in economic benefits. That's a pretty big range. So it shows that there are, you know, very many different ways of doing this with very many different impacts in different contexts. But when we looked at what the aggregate number was, we tried to average that out, and the full report is available online. I have one precious copy here that I'm not giving away, but for those who are suspicious of this kind of calculation, there are many. There is a full methodology at the back of this report, which is also available online. So you can decide for yourselves whether you think what you think about this. From my, you know, in my view, these things aren't necessarily, we shouldn't necessarily take these as in exact science, but they're certainly very strongly indicative and help, I think, to us to understand the costs and benefits of all of the different calls on government money, and help in terms of prioritizing and understanding some of the consequences of where we put resources. So when you look across the board, for every, you know, you sort of average out these different studies using a weighted average to try to take into account the different circumstances and so on, you find that on average, a single dollar invested in a data system will deliver $32 of economic impact in return. And this, of course, comes in through a number of different channels, which are all detailed in the report, depending on the sector, depending on the particular circumstance. This can be increased life expectancy. This can be increased economic opportunities available to farmers. This can be reducing the impact of climate emergencies and disasters. There are very many different channels through which this impact is felt. But overall, the message here is that investing in data is an incredibly good investment as investments goes. I think my understanding is those of you who are in this sector can correct me, but this is sort of on a par with the studies on the return to investment of investing in vaccines. I think, you know, we're talking that sort of level of a foundational basic investment that really underpins progress across a whole range of areas. But I think, you know, there is a huge data dividend here. There is a huge benefit waiting to be unlocked. And I think as we saw, as we heard yesterday so powerfully, that we're really missing the opportunity to benefit from the possibilities here. That I think, you know, I was really struck yesterday by Alan's diagram of Uganda and all of the different piecemeal and sort of fragmented investments in digital systems in Uganda. I think we're seeing a very similar thing in data. We're not reaping these benefits of this systemic wide investments across the board, because what we're seeing is piecemeal investments, is, you know, investing in one survey here, one platform here, one experiment here. And we're not really looking at the whole picture. We're not making the kind of investments that can pay off again and again over time, and again over different sectors, parts of the economy, different services, and so on. I think one of the challenges that we face here is that many of the incentives which are underpinning investment in data, particularly those which where countries are perhaps more dependent on external resources, act not to help us to pull systems together and coordinate investments, but actually rather create incentives for a more fragmented approach. So, you know, we heard yesterday, I think, again, very powerfully, some of the challenges that are created through the donor landscape by the plethora of different surveys supported by different agencies. Sometimes, you know, I think we all probably have to admit that the SDG reporting poses its own challenges for a fragmented system and doesn't always help governments to set their own priorities. And then, of course, we have the many different calls on the resources of a very hard-pressed data system, including the need to support the monitoring and evaluation requirements of their main donors, and the need to be constantly collecting data, which is not always the highest priority for delivery of government services and the meeting of government priorities. So I think we're confronted with a system where the absolute amounts of money going into data are not sufficient, where data, you know, despite the huge amount, the huge new opportunities in data, new technologies, new data sources, since the SDGs were agreed, the amount of money going into data as a sector has remained almost static. So we're confronting a situation where despite the evidence on the huge benefits, the amount of money that's going in static and the way in which money is delivered is often not helping to really reap those benefits by coordinating across sectors and across the system as a whole. Just as one example, which particularly enrages me, in Zimbabwe, I don't think we have anyone here from Zimbabwe, but in Zimbabwe was in a situation where they conducted 33 different surveys in 9 years, supported by, I think it's about 10 different donors. You know, and this is a cost. We don't know the exact cost of each survey, but as you all know better than I, the average cost of conducting these kind of surveys hovers at somewhere around $1 million or just over. And so if you think about the total amount of money there that represents, that could have been spent in a way which actually strengthened the whole system rather than fragmenting it, I think, you know, we really could do better here. Fortunately, as I started, I think do have an opportunity now to do something about this. As I said, we're working closely with the UN leadership, with Mala's colleagues in the World Bank, with a number of different member states and governments, some of whom are represented here, to really say, can we build on this momentum that we have, both the increasing amount of evidence about the importance of data, the increasing calls in rooms like this across the world in different sectors for change, and the political opportunity that we have over the next few months. We can't solve the problem between now and September, but we can at least set ourselves an agenda with political support to tackle it over the coming years. So can we really coalesce around an agenda for these next few months and really, you know, expend all of our political resources to try to align over some specific changes? So we're working closely with a number of member states in the G20, with the UN leadership, with the World Bank, to try to pull together an agenda for change. At the moment, this is framing around these 3 core pillars. So really interested in feedback on those, as well as any other comments that you have. And the critical thing here is that, first of all, there is a focus on partnerships at the country level, and really partnerships not just in any individual sector or in any individual, you know, focused on any particular area of data or technology or methodology, but can we use this moment to get the political leadership at country level to pull these things together, to get donors to coordinate at the country level where that's a relevant part of the equation, to bring different ministries together, to really think about the system in the country as a whole through partnerships. The second is really tackling this challenge of capacity. We heard about that a lot yesterday. That's something that comes up again and again every time. Can we really get a concerted effort working together? There's a huge amount of institutions and resources out there which are trying to tackle the problem of capacity. They're not always easy to find. They don't always work well together. They're not always tailored to the specific needs of particular country challenges and so on. So could we do better both at using the capacity support that we have and filling the gaps where we're needed? And then thirdly, can we tackle some of these challenges around the donor incentives and the ways that donor support to data is organized through getting together a group of donors who want to work together to solve this problem, both through country partnerships and by setting themselves standards and goals globally to cover the whole area of operation. So I think through this, we do have an opportunity now to at least begin to set ourselves on the path so that when we all convene back in this room in a few years' time, we're not talking about the same things. We've changed this story with political leadership, with resources, and with the hard work of everybody that's in this room. So, I'm trying to control my expectations because these things, are difficult. It's a hard road ahead, but I do think we have a great opportunity, one that certainly in my years of working in this sector, we've never had this level of political attention to this agenda. I really want to capitalize on this opportunity and really look forward to working with all of you on that. Thank you.
Thank you, Claire. Also, we're getting a lot of requests online that they would like to have access to the report. So if so you can share it with us, and then
I'll give the colleagues I'll give someone who's on the Zoom a link to the report in a minute, and then you can put the link directly into the chat. Okay.
Great, thank you. And also, excuse me, all the background documents and other reports that you're hearing about will be made available by the Secretariat. So you'll definitely be getting access to this report. Thank you very much. And so now we're going to move on to see the rationale for investing. So we've heard the numbers. Now we're going to hear from Xavier Bosch-Capblanch, who's the project leader of the Health Systems Support in-person unit of Swiss Tropical and Public Health Institute, and then from Christian Auer, the public health specialist, also from the Swiss Tropical and Public Health Institute, on behalf of the Health Data Collaborative Routine Health Information Systems Working Group. They've done us, maybe you can just start off by explaining, and thank you.
Thank you, thanks to you. So I think I have half an hour or 3/4, so that's very good. Yes. So good morning, everyone. This is really a pleasure to be here with you and share our findings. I am presenting some findings of our work on behalf of the team. My name is Xavier Bosch-Capblanch, and I am working at the Swiss Tropical and Public Health Institute. I am project leader and associate professor at the University of Basel, but more importantly, I have been 10 years working as a medical officer in rural African settings, where I have had actually direct contact with the routine health information system and with the pain of the routine information system as well. And Christian Auer, who is with me, he has been 15 years in the Philippines. He has a long knowledge on health systems, and particularly with tuberculosis. Fabrizio Tediosi, who is a health economist, and Margaret Bata. And also we have partnered with the South African Medical Research Council, with Natalie Leon, who has done the Cochrane systematic review on the effects of interventions to improve routine health information system. Edward Nicol, who is a specialist on health information system from South Africa, and also Donella Besada, who is our health economist as well from South Africa. No. Yes, I am in the big button. Good. So can you pass the next slide? Now, thank you. Have I done it or you did it? Maybe I did it. Okay. Yes, good. So let me give you a bit of the underlying perspective of our work. So our work is focusing only on routine health information systems. And there are several definitions and frameworks around about what is the routine health information system as opposed to other subsystems. But we basically agree that this is the system that takes place and starts at the healthcare delivery points, is where is institution based and is where patients and public get services. And actually, if I would resize a bit the graphic, I would rather, as I will try to justify later on, highlight that in terms of size, really the routine health information systems, the institutional based, are extremely much larger than the other components of the health information system. Also, from a historic perspective, we have been looking at at publications about different topics that I think are relevant to the routine health information systems: human-centered design, health technology, systematic reviews on health information systems, equity. And it's interesting that there has been a remarkable increase of publication from 10 years ago. So I think that when we are thinking about routine health information systems, we really have to be sensitive to actually new knowledge that has been produced relatively recently. And also we have a reality perspective. I mean, these are pictures from 3 different countries. These are not particularly picked pictures. This is something that is rather the rule than the exception. And let's not forget that these are the sources for data that goes upstream, up to the international community, up to the Sustainable Development Goals monitoring. So clearly, as you know very well, garbage in, garbage out. Any error that or problems or mistakes that happen at the peripheral level will only transmit and amplify towards the higher levels of the system. So let me take you through a few methodological considerations. The reports would be available, so I will try to be really brief for the sake of the session. So we have done a scoping review of the literature, trying to capture examples of routine of investment cases on health systems interventions. It is relatively easy to find that for biomedical interventions, but not so easy for health systems interventions. So we have scrutinized the literature and we have ended up with 17 relevant papers that we have described in the report. Also, we have done country case studies in 6 countries, in Colombia, Cote d'Ivoire, Nigeria, South Sudan, South Africa, and Nepal. Unfortunately, we don't have yet the data from South Sudan for logistical problems, but we are finalizing this week and we will incorporate this in the final analysis. I promise, before you complain, I promise that. And we also have two subnational areas. One is Cross River State in Nigeria and Western Cape Province in South Africa. So we have also done an economic analysis, and this analysis is based in 2 main parameters. One is in the cost of the routine health information systems, the data that we have obtained from countries, and also the healthcare access and quality index that is produced by the Global Burden of Disease, which was published in a Lancet paper that we have used to estimate lost welfare. So I would like to tell you to go now through some of the findings that we have. One really is to realize that the routine health information system is really special. Every single worker in the world will be in touch with the routine health information system, will enter data into routine health information systems. This is 65 million people. This is the population of France that every time, every day, in every encounter, clinical encounter, public health, laboratory, pharmacy encounter, are going to feed into the routine health information systems. It's running in any country. It doesn't matter the level of development, always. And very importantly, the point of data collection is exactly the same place, the point of healthcare. So actually the routine health information system, very different from the rest of the information system, is a quality of care process, is a healthcare process, is a biomedical technology, is not merely an information tool. And of course, the carrying of personal information has very strong data security issues. We have looked at qualitative evidence from the countries on what works or what has been reported and the problems. So we can only underline our concordance with what was yesterday shared from our colleagues from South Sudan. Again, I think this is rather the rule. I would like to call your attention only on the last point, which is these red acronyms, which is what our teams reported from the countries in terms of subsystems of the routine health information system. So there is a massive proliferation of subsystems and sub-technologies in the routine health information system. And also we explore a bit what are the consequences of the COVID-19 pandemic, and mainly this created some problems in the reporting of routine data, and also created, again, duplication of reporting mechanisms. We also did some semi-quantitative analysis of different components of the health information system. And here in the lower part, in the lower half of the slide, you have our findings, and in the upper half, you have the score findings. And it is interesting because they are quite coincident, and we could order the countries in the same way, which also was useful for us as a kind of an indirect way of validating our findings. If we want to answer the question of what works, what doesn't work, I think that really the most sensible approach is really go to research, is basically research and particularly systematic reviews that can answer the question of what works and what doesn't. And here I just put the systematic review of Natalie Leon on interventions to improve routine health information systems. So in terms of the funding of routine health information systems, we have information not from all countries, but from some of the countries. We have been able to collect some data, and really the government budget of routine health information systems in relation to the health expenditure is really marginal, 0.2, 0.1%, or even less than that. However, from the whole routine health information system budget, the external support is substantial. It has been reported to be between 20 and 30% in different places. We have also estimated the cost of the routine health information systems with minimum, midpoint, and maximum to have some level of uncertainty, which goes into the millions of US dollars per year. But I want to call your attention on the data about person hours that are used per year in routine health information system, which goes into the millions. So for example, in Nigeria, more than 40 million person hours per year are used, not on healthcare, on routine health information system. So if we think any private enterprise or business that has workforce for 40 million person hours per year, you would expect really a lot of outputs that I don't think we are getting from the routine health information system. We also looked at the costs by domain, investments, routine costs, human resources, and constantly in all countries, the highest proportion of cost are in terms of human resources. And if we look, I didn't show the data here, but if we look at how the costs are distributed between central, mid-level, if you wish, and peripheral level, the majority of the costs are in the area of in the peripheral level of the system in primary healthcare. We also estimated, as I was mentioning a minute ago, the value of lost welfare based on data from 2015, and then estimating this for 2022. And we estimated the proportion of the cost of the routine health information system in relation to lost welfare. And these figures, which is the last column, are extremely meager. So this would mean that if you would attribute being pessimistic, if you would attribute like 1 or 2 or 3 or 5% of improvement of healthcare in routine health information system, this would justify investment of 100 or 500 times at the very least of what we are investing now. So there are extremely tricky methodological issues in return of investment. Some of the estimates included in the Dalbert report are based on studies, but these studies, we have to look at the quality of these studies, because studies that are weak are full of biases. There is, of course, publication bias, selection bias, outcome bias. So, and there is a very large heterogeneity of not only study designs, but also sectors. So combining data on a return of investment is really possible because it's a mathematical issue, but does not really make sense all the time. And in our literature review, we have also found that the examples that are actually bringing return of investment are examples of very small interventions. So you can do, for example, an intervention that is related to electronic medical records, and then your outcome is length of stay. So this is very minor, and is of course is connected, but because it's very minor. So when you look at the system perspective, you lose a bit of the relevance of this data. So I think our main conclusion is that, as Craig mentioned sometime, is that routine health information system is the poor cousin. I mean, this is the most important, the unavoidable, the most needed health information system in the world, and it has very little attention and marginal funding. This really is the complete reverse that what we need. Of course, we have dared to give some menu of things that could happen or that could be taken by different stakeholders, but I would like to call your attention on two issues. One is that for some actions, we don't need more evidence, we don't need more studies. Sorry. Yes, I was passing here. So for some of the actions in green, we really don't need more evidence. We have to stop doing some things, and this is just a matter of political will. And also the other aspect, and I think that it was very much mentioned yesterday by Kristen in terms of the legal framework, is that if routine health information systems are process of care, maybe we should think about putting them in the same processes that we put other biotechnologies, so using processes like health technology assessment or the regulatory process of the FDI or similar bodies, because really we are not talking about only data, we are talking about mainly quality of care. So this is my last slide, and I think we really need a shift of paradigm. This is not a matter of fixing a bolt, changing a wheel, it's really to changing our mentality. Data and dashboards are certainly very important, but what we are talking here is about patient care. We need, of course, technical approaches, we need all these technical discussions, but we need systems that are responsive to humans and to users. We are rather speculative on the use of data. I have been in many meetings where I ask, well, use of data for what? And then I don't get anything specific, but I think we need to really look at the decision space of the users of data. And the decision space of a health worker is different from a district manager and is different from people in this room or policymakers at national level. I think we have to stop this issue of blaming health workers and training health workers. This has really to stop. We have to improve the system. If for a system you need so much training, so many years to so many people, I'm sorry, there is a problem with the system, not with the health worker. Also, in terms of evidence, we are basically using observational research. Observational research is pregnant with bias, whether we like it or not. I know that experimental research is more difficult, is more expensive. But this is what you do when you want vaccines and when you want drugs and new devices. You don't use observational studies, you use experimental studies. So if we are serious about routine health information system as a process of care, you need as well experimental studies. Also, this has been said before, the issue of pilotitis and multiple, no, there is something that is missing there, I think. We really need to start implementing. There are frameworks because in biomedical sciences, this has been very well described. We need to stop doing things that are harmful. So we need really frameworks to implement and stop doing some of the things that we are doing in order to do the new things. And finally, which is the sentence that is missing there, I think we need governance, not of bad systems. We need good governance of good systems. We can have good governance of bad systems, but that is not, I think, what we want. So I have to really thank a lot of people. Many of you have contributed, have helped us. not to mention Craig and Carolina. Carolina is the most efficient person I have met in the last 5 years of my work, and we really fear her emails. But thanks really for pushing us, and thanks to you for your attention.
Thank you very much. So lots to think about there. Now, I have down as Craig. Sorry, I think you're after, sorry. Craig Burgess, who is from the Secretariat, who's going to speak more about SCORE.
Throughout this work that Xavier and the team took on board, huge thanks to the amount of effort that's gone in. And we actually constituted a group of external experts as well to complement that and support the group from a strategic point of view. So I'm actually presenting not from my point of view. This is the point of view of the external group. Unfortunately, Sally Stansfield, who we'd actually asked to present this, she couldn't make it on time. She may come this afternoon. So I'm presenting on behalf of her. We constituted a group that could help Xavier and his team as this work progressed, really with a strategic approach. You see the names of the people there. It included Sally, who I think is well known to many of you in the room. She was the previous director of Health Metrics Network. Bob Pond, who I think is known to many of you as well, independent consultant. Theo, who describes himself as the dinosaur of health information systems. He was writing books about it in the 1980s. Dejan Lonkar, who's a health economist. Thanks to him, a lot of kind of economic inputs from that. Juliet Fleischl, who's a consultant and has been a previous WHO representative in multiple contexts. Julius Marcus, who kindly worked with us from GIZ, was the suggested name. Thank you for GIZ. Michelle joined us when she could from the Global Fund. Bill Weiss from USAID. Shada Beatty from Open Data Watch, and Joran Bra from the University of Oslo. So there are 10 experts that helped shape some of this work. There were 4 formal calls during the process of the work, and we also had informal calls and advice from them. And I've only got one slide, which helps kind of summarize their inputs into what Xavier has inputted. So next slide. And their key thoughts on this was really, don't underestimate, this is difficult work. And as Claire has highlighted, there's a huge amount of technical issues about how do you get return on investment. It's difficult, it's not easy. And perhaps in this scope of work, it wasn't going to be possible right from the start. The terms of reference were we wanted is it possible to get a return on investment figure on RHIS? And I think the bottom line was in this scope of work, no, it's not possible. It doesn't mean it's impossible, but not possible with the current scope. So just if you're looking for a figure of like dollar for dollar, it wasn't possible in this scope. I think the second thing that they were really strongly advocating for was rather than a specific investment case, really get some really good country examples of what works in local situations, of how things work in terms of investments and what doesn't. And usually it's getting the right message to the right person at the right time in the right format and influencing political and budget agendas accordingly with good evidence on local levels. So this issue of kind of country case studies was really came up, and that's what Xavier has presented. The other thing they suggested was RHIS is special, indeed very special, and at the heart of it are people, but it's part of a much wider ecosystem in health, the health information system, and beyond that, as Claire has highlighted, a broader statistics and data system beyond health and multi-sectoral. So they really emphasized, is there any way in which we could link in with national statistics offices and other systems as well, which is what I think Claire has highlighted, which is the whole reason for making sure we're thinking a bit broader as much as possible and thinking about data as a strategic asset. The other suggestion they had was have a counter argument. What would happen if there was no investment in routine health information system? And I think we all know the answer to that, but it'd be good to kind of document that. Communities left behind. Don't forget that in the SDG agenda, which is a lot of what this is about, it's about communities left behind. And many communities left behind live in quasi-legal status, in fragile settings, in urban poor, in rural remote. We all know that. But where perhaps governmental systems, we heard from our colleagues from South Sudan yesterday, much of the data comes from non-governmental organizations or private sector as well. So their other advice was really embrace the power of partnership with private sector and with NGOs, because that's where a lot of the data comes from. And a lot of health workers are actually employed by the private sector and NGOs as well. The sixth thing they had in mind was, again, I think I've mentioned it, don't think investment case. Sometimes there is almost too many investment cases competing for attention. It might be better to look at it from a financial, technical, and political resources that are required by a government, for example, as part of their national planning process and their national budgeting process, and look at it from that point of view. And then lastly, I think we all get caught up, and many partners who'll be here with us this afternoon, it's not necessarily they're not providing the majority of funding in countries for health information systems. It's actually ministries of finance. And perhaps, this is a question mark they had, the target audience for when we're talking about investment should be much more focused on ministries of finance and the way in which ministries of finance negotiate with the different ministries actually in countries. And that should be the target audience for some of these key messages. So they also identified some gaps. And again, these are just suggestions from the group. I think they acknowledge it's very difficult work. And there is a lot of attention and a lot of interest from many of the global health initiatives, some of whom are here today and will be here this afternoon, Gavi Global Fund, GFF, and the World Bank as well. We know there's a lot of interest, and can we make sure that we're working together to fill some of those gaps? Where are the biggest investment gaps? Where are the biggest gaps in data? Second, there is a paucity of some of the costing tools, specifically to highlight the inputs into some of these models that have been discussed by Xavier. And again, I kind of want to emphasize again, they're really pushing us to think about making from the output side, make the economic and social argument and link it to the SDGs when we're talking about investment. And I think lastly, and this I think gets to the kind of the passionate last slide that Xavier was presenting, most of the investment and most of the needs are at sub-district level. It's at health facility level. It's working with people, and it's about delivery and making sure data is used for action. And that data is really difficult to get. When you're looking at investment and an important part at subnational level, that aspect is the hardest part to actually gather. And it's not easy. So there are no answers there, but those were some of the gaps that they wanted to highlight for you in the audience. And we hope that some of you pick that up. So back over to you, Samantha, and thanks Xavier and team for all your work over the last months. And thanks to the Routine Health Information Systems Working Group that really helped push us in this direction on behalf of the HDC, which contracted to you to undertake the work. So thanks very much. Back over to Samantha.
Thank you very much, Craig. And maybe Christian, you can just speak from here. Christian just had a comment to follow up from the Swiss Tropical Health Institute.
Yeah, I just want to highlight one of the aspects where I feel it might be in danger of being neglected. So what is actually crucial when a mother with a child, for instance, goes to the health facilities, what really happens in that interaction between the healthcare worker and the client. And when we think of the health information system, we really need to have very much in focus also, what is the effect of the tool on this interaction between the client and the healthcare worker? Because we know, like one thing with tuberculosis where stigma is important, if the healthcare worker is not relaxed, but is struggling with filling in papers, it really affects the quality of care. And even if we have a very good system above this interaction, something vital is really not going well. So when we invest in health information systems, we really need to think very well of this interaction. And we have done a project in the last 6 years, and the coffee break or so we can discuss more. Thank you.
Thank you very much for that important point. So it was raised quite a lot yesterday as well that, you know, it is in the end about helping the patients and strengthening the health system, not about data for data's sake. So thank you for that. Right, we're now going to move on. Now we are going to be talking about SCORE from different perspectives. And I have here Jennifer Ellis. Is she around? Video, sorry. And then we're coming to you. We are coming to you. Sorry. Okay. So Jennifer Ellis from Data for Health Initiative, Bloomberg Philanthropies online. Thank you.
Good morning. I'm Jennifer Ellis, and I oversee the Data for Health Initiative for Bloomberg Philanthropies. We launched the Data for Health Initiative in 2015 with priority country partners as well as multi-sectoral international partners. When we started, we saw right away that, in large part because of the critical efforts of the UN to draw attention to the need for better health data, there was considerable interest in work in this area. In addition to forming close partnerships with our priority countries, we also wanted to support our international partners in providing resources that could support action around health data for all countries. Our partners, including WHO, raised from the beginning that though lots of calls to action had inspired interest, what was missing was clear, actionable information packaged for use in one spot that could support country-level changes. From that, we funded WHO to develop what became the SCORE technical package, which was put together over several years, beginning in 2015, and released along with the first ever status report in July 2020. The work of the Health Data Collaborative has been instrumental in continuing the conversation about better data for better health, particularly around the critical need for increasing investments in health data. Our hope is that this SCORE technical package has helped to continue to inspire interest in country action in improving all aspects of health data and has provided clear pathways to tools to support action and measures to understand where action is needed. This week's meeting is a great opportunity to combine these areas of work to support further action. Making an investment case to support health information system strengthening is a key part of the process in ensuring real change. Our hope is that SCORE provides countries with a framework to support conversations and action on investment in health information systems by ministries of finance and international partners. Thank you to the HDC for hosting this critical meeting. I'm sorry I can't join this morning, but I will see you in later parts of the meeting, and I very much look forward to hearing about the discussion. Thanks again.
Okay. Thank you very much, Jennifer. Now we will move on to Anne Chu finally from the Health Information Systems, DDI, WHO. Thank you.
Thank you, Samantha. Just this slide down. Right. So my name is, it's okay? So my name is Anh Chu, and I'm the focal point for the health information system. And the in particular, lots of work putting on the routine health information system in WHO, the data analytic department in Geneva. So just follow up, and now my roles is quite difficult after a very in-depth presentation and discussions of the two previous speakers, Claire and Xavier. Just stepping back and follow what Jen has said about the health information system. So we look at the global perspective, and now we move into the country perspective. In the previous presentation with Xavier, we have that orange V-shape of how the structure of the health information system. And for the SCORE technical package, we look at it from a different perspective. The whole idea here is that we shape it into 5 interventions. The first 3 that is looking into the data sources, the data collections, and the sources for all the data that's going to be used in the R, which is the review, the data analysis, the use of that at different level in the health systems and by different audience, and the E is what enable all of that to put together. And remember, there is no separate; they're all interlinked. They all work together, and that is a interaction between each of the interventions. The objective of it is to provide a landscape framework where we see where the structure of the health information systems, and it aim at look at the capacity, how the country would be able to monitor the progress toward the achievement of the SDGs, the universal health coverage, And don't forget also some of the key targets of the socio-economic development and the health development that the country set up as well. And the idea here is that it should not be separate. This M&E framework should be put together as one framework. And what is the country capacity to be able to monitor this, and I think that would be compiling of all different data sources that mentioned in the first three letters, the S, the C, and the O, which is survey, the COW, which is mainly for civil registration and vital statistics, and mainly also on the cause of death, and the O, which is optimal facility-based data and community. And that's very much linked to the routine, but also we look at what facilities needed in order to, number one, provide an essential and important and the service and quality service to the populations. And number two is to make sure that they understand the populations that they serve, but also to know that they have enough materials and data for their planning. And then we also provide that on top of all of this framework, there is another part of the score, which is providing the tools and standards that has been collected. So there are 500 different tools in this package that suggest and provided for the country to use once you have the identify the gaps and the plan for enabling and strengthening the capacity of the routine information system. So this is a SDGs framework. It comes with an assessment, and the assessment, and we are planning to do the second assessment in 2025. The first assessment already have been reported in 2020, as Jen said earlier. So the framework is built based on a three key structure. Number one is that there should be an optimal goals and objective for each of this intervention of the health information system in terms of meeting international recommended standards, in terms of the data, in terms of the structure. Number two is that there should be a governance part of that included with an inclusive plan for the government health information system plan and a budget to come along with that. And finally is a plan to build the capacity in the countries and how we work together to do that. So we have 6 different materials. Just I don't know how to. So we have we have 6 key documents as part of this package. I'm just paying attention to the first 2 here, which is the key interventions and the tool standard, which is something that should be disseminated in all the countries should be aware of what is the ultimate requirements for a health information system in the countries and what are the tools out there for you to use. And then we have the instruments for the assessment that ideally countries should be able to adapt and use it to monitor your own progress after you have done your health information system strategy. And then we also have the report of the global assessment and the guidelines on how to use them. So I'm just going very quickly through these 5 interventions of the health information system framework that under the SCORE framework. And then we based on that is the result of the assessment to identify what are the gaps that has been identified. So the first intervention is look at surveys, that means population-based survey, the census, and the public health surveillance. So this very much of to look at, again, what are the requirements, international recommendation standards that each of these surveys is done for population-based surveys and also for the census. And particular for the public health surveys, it is the IHR that we need to look at and all the WHO recommended procedures and standard has been, most of the country has followed. And we can see that in general, if you look at from the global perspective, it is above average. But if you look into the specific per country, we'll see that the low and the middle income countries, mainly in Africa, Middle East, Southeast Asia, and the Pacifics are the ones that need further investment and support in terms of strengthening the capacity for public health surveillance and the census. Right, and here's are the tools. We just have collection of all available tools until 2019 to publish in this package. And the plan is that in the next round, we will revise this tool and make sure that there's update of the tool, but also what's outdated need to be sorted out. And come with that should be a guidance for country to know how to identify the tool and who to look for the support and how to use the tool. And Claire mentioned earlier is about, the multiple surveys, and even sometimes it's like a census that's conducted in country when there is an ask for an indicator, specifically on SDG indicator. And the WHO Survey Plus, Health Survey Plus package has trying to and has been developed for that purpose. So harmonize all the health-related surveys in complement with others, sort of more big standard survey like the DHS, like the mix. The idea is that if any country wanted to look at program-specific health survey to monitor or to report on the SDG, they should be able to conduct it and have it in a way that we can save the resources, especially save the human resource and funding, so that we can have all the needed data that based on the population-based survey can be done in this. So this is a modular tools that WHO has been developed in the past few years. And this is the work that DDI has led and across different departments in WHO. And we have all the materials and the guidelines and the metadata, every questions and everything is in the websites that we can provide that later. The second part of the intervention of the second intervention of the score is on the CRVS. So lots of discussion on this, but I think COVID is overall has really highlighted the importance of CRVS as part of the health and what is the health and contributes also to the CRVS as well. Here we look at the two things. Number one is the registration of the birth and deaths, the regular monitoring of the population of knowing where our population is, who they are, where they live, especially if there is in specific, like I just came back from Cairo where there's a loss of movement of population because of refugees, because of migrations, to understand, who are in the populations in the country, where they stay, are they part of the overall population that we serve, and make sure that there is no one is left behind, make sure that the equity is addressed, and that is all there through the birth and the death. So that is to end of the life, the book of the books of life. And then in between that is on the movement, on the marriage and divorce, children's, all of that need to be counted in. Secondly, and that is the COVID's excess mortality has really given us a wake-up call where more than 90 countries did not have a data on mortality. And that all of that have to be done through on the models. And I think this is the important, and this is also the time to say that we need to look into this and support and work together to get all the mortality data in the community. And then from there, from the health sector, we can contribute more in terms of getting the cause of death. And a lot of work also has been done in this to get a better diagnosis cause of death, a timely cause of death, but then combine all different data collection methods that we could have and strengthen and support the coordination across different sectors in the country as well, so that we could have a better understanding of the population we serve, but also that would help us in terms of getting the cross-border discussions and data governance as well. In terms of the tools, we have a lots of different tools that look into both in the birth registrations and death registration and cause of death. But the main point here and very specific for CRVS is that it touches a lot of different sectors. In all the country, there will be at least 3 different sectors involved in the CRVS, how we work together, how we share the data. The birth can happen in the facility, it can happen at home, it can happen abroad. How we're going to count all of them into our population, into our civil registration and vital statistic data. And then from there, how does it use it? And we serve the purpose of the health planning. We need to break it down to the subnational level. We need to bring in those who are not registered. We need to know where they are. And then from there, we can plan and serve the population better. And this is another angles of the CRVS linkages with health that we haven't looked into it a lot, and we need to explore more and find a way to work together. Because if we have a population, a subnational level, we talk about a lot about the data used at the district. We will not be able to know how to plan our district and facility services if we don't know who we serve and where they are. And I think this also another part of link with the GIS part. My colleague Ravi will talk about that later. And then Xavier has talked a lot about this part, the routine health information system, but also other data collection systems that build in as part of the facility and community. So we have a routine health information systems. And here I mentioned the systems, not system, because underneath it, we would have every single data collection systems that required to ensure that the facility, number one, knows who they serve, where they are, and what composition of the population. And also to help them to know what kind of burden of disease or what kind of common condition that they come to receive the service. We also need to see that what else are out there. For example, we have the facility assessment where we know which facility that available.
Sorry, excuse me, Anne. Sorry, we're running really late. Do you mind just really summarizing? And
I need another 5 minutes. Otherwise, it's no point.
Okay.
Yes, thanks.
Okay.
So we need to really see and combine different data sources from the assessment of the health service to know if this facility is ready to provide the services and have enough on the equipment, on the commodities, on the infrastructure is needed, including human resource, including finance, including infrastructure. So all of this is part of the analysis and also bringing different data system. And we talk a lot about the sharing of data, the integration, the interoperability, and this is where it comes. But also this intervention look at the standard structure that required to have to enable this interoperability and integration, such as the standard of the master health facility list, the standard for patient ID, the standard for metadata, how they can work together and ensure that there is a basic structure for data sharing, regardless of what of the tool that they use. And here I also mentioned the two latest tools that, and standard has been developed recently. Number one is the Routine Health Information System Toolkits, which has been used across 70 countries that use the HRIS2. It's one of those 33 plus packages now to ensure that there is common standard across different data system, different programs that can be used and pulled together for monitoring of the services, but also for reporting for the progress of the health plan in the country. And the second tool is on the harmonized health facility assessment tool, which is, as I mentioned earlier, this is a comprehensive modular tool that has all the questionnaire needed in order to help the country to assess what are available in the country, what services available where and how, and the proportion of that across the health facility. And then also we look at the quality of care in here, we look at the system structure, and we look at the availability of commodities and assessment and essential drugs and all the needed for the services. So all of these materials are available. And the idea is that if the country identify any gaps on this and needed for the planning, they know where they look for the materials, the guidance, the training, but also this is where the call for the partner to see if you are part of this is part of your support, that we need to look at that and how to find a way to work together and collaboratively implement these tools for this purpose and support the country. The R, which is the data use and analysis, but also building capacity. This started with looking at how countries use the data that reported through all different data sources and how they can contribute into the development of the health development strategy. But I think it can go beyond that as well. It should be used on a more regular basis because if the strategy is 10 years or 5 years, we need to break it down more regular. Secondly, it is also used for equity. We just launched the biggest database on equity that come from all different data sources in WHO. Together with that is the tools to how to use that, how to analyze this. And this is something that very much essential, and a lot of partner as well as country now wanted to look at perspective. So we need to look at it to see where the sources of data for equity monitoring is coming from and how we can strengthen that, how we can put it together and what else is needed. And personally, I think it's good to start with the survey data, but at some point, if you want to really to look at into the leaving no one behind, we need to bring in other data sources as a routine, as community, as a population CRVS, because it is about touching those we are not registered, those we are not seen, the marginalized, and I think that is very important. And there's a lot of materials are here. There is training courses, there's also data, and there is support to be provided from the WHO equity team. And finally, enabling. We talked a lot about that yesterday, about government governance, also about collaborations. The digital is one of the key driving for making all of what country have been trying to strengthen the capacity easier. But I really like what Steve said yesterday. If we are going to digitalize and modernize the structure, we need to first have a decent and a minimum requirement is needed to have that structure in place before we're going into digitalizations. Otherwise, that will be very easy for fragmentations. And when we have seen that in many countries. So there's three key things in enabling. Number one is there is a structure in the Ministry of Health that focus on data. We ask for a health information system departments with capacity, with competency list. And one of our regions in Western Pacific have just launched the equity competency requirements for health data workforce. And this is something that we will continue to look and see how we can broaden it further, and it should be a global tool for that. And it'll be amazing that how many different skills is required if you are having a comprehensive data team in the Ministry of Health. Secondly is we have a legislation and governance structure for collaborations to make sure that the data security, the confidentiality, cybersecurity, all of that need to be put into laws, need to have an enforcement, but also control to make sure that people feel safe to share the data and also to enable all the resistance into sharing data and interoperability and integration of the data system. And finally is the need to have a regulation, but also to work together with the digital worlds to bring the digitalizations into the health sector in a more structured way through the digital strategy or e-health strategies, which is I think it was probably happened, like it was called in the past. I remember 2013 when Mark was organizing that at the AHIN, and we had that training on the e-health strategy, and now it's a digital health, it's a bigger term. But all of that need to be seen as part of the framework, and countries should be able to first look at what has been the finding of your country in the assessment of the score, identify that what has been the gaps and how does it link to your capacity in monitoring the USC and the SDGs. And then from there, we need to work across different sectors, to work with the government, to work with the Ministry of Planning and Finance and all the partner to see out of that, what would be the priorities for the 5 years, 10 years, how we work together to have a one vision, one plan, one budget. And I think if we have that, and also I see the need to strengthen and to empower the country's leadership. If they see the one plan and one visions and the budget, there's a way of not controlling, but working together with partners and building the capacity. So to use of the data, and then from there to build a structure based on what is needed apart from the SDG and the USC indicator. There's a lot of more underlying indicator underneath that in order to monitor the progress. And I think that needs to be also delivered, that message to the Ministry of Health and the government, so that they see it is not something just for the global report, but it is something that benefits them and bring that down to the subnational level. So with that, I'm going to pass it to my Pakistani colleagues, Dr. Naeem, who is going to share some experience from Pakistan. Thank you.
Thank you.
Okay, thank you very much. My name is Dr. Ali Shirazi. I represent WHO Pakistan, but I'm here with Dr. Naeem, which was the name was mentioned, who is from Ministry of Health, and we together, basically, I'm presenting on the behalf of the government. So a little bit of reflections on what we are doing in Pakistan. I think mainly the challenge is the fragmentation of the data that during the past 2 days, it has been mentioned more and more. But in Pakistan, the system is decentralized. It has been decentralized. The power is with the provinces. There are 4 big provinces, and each one of them control the budget. So some of the policies come from central, and then the rest are in the provinces. That means that this fragmentation has even augmented in the provinces. Each one of the provinces has a lot of different platforms just for their own province, for the data on different vertical diseases. There was a study, for example, in the biggest provinces, Punjab, probably they have more than 70 or 80 different parallel platforms that are collecting data. These are for vertical data on malaria, TB, HIV, name it. And then there are other things related to the facilities, for example, SARA surveys, system availability, for example, that we do. So what I want to say here is that in terms of score, if I want to mention, there are so many surveys that we are doing. There are the MIS for the vertical surveys, as I said. Even they have surveys for the LHWs, for example, lady health workers, that can be separate from the HRH survey, which is the human resource for health. So there are so many of these things. What we're trying to do is to consolidate, to make it less and less surveys, and more, first of all, work for the routine health information system. And what Xavier mentioned in the morning was really resonated as for me coming from the country, that if you improve the routine health information system, not only you are getting the data, but that's a big aspect of the quality of care and patient safety. This decade is also patient safety. It is part of the quality of care. So this really goes hand in hand. And then you will look into the end point, which is helping the population health, helping the people, individual people's health to be improved. So that is the message that I take from here, and it's very important for us in Pakistan. Underscore other things that I can mention under SRVS, civil registration and vital statistics. We are working with the government for the ICD-11. And again, another point comes here is that it is not only Ministry of Health, it is the statistical offices, it's the planning offices. So particularly things related to the registration data for death and birth and things like that, it goes a lot beyond the work of the Ministry of Health. We have to use the convening role of the UN also here, and we are trying to do that in order to bring all of these different elements together. One survey which is very important along all of these disease surveys that we are talking is the SARA survey, which we did comprehensively in Pakistan, which is service availability and readiness of the facility. So unless the facility is ready, then you cannot do things. So that is another thing I want to say. And perhaps the last point that I want to make is that we did also something called CPEA, which is the cross-programmatic efficiency analysis. So I represent the health systems, but we worked with the colleagues on the disease, on the vertical diseases, on HIV, on malaria, on TB and others, and with headquarter and, regional. It's a big group, consultants and all that, to see where we can improve the efficiencies and bring the health system as a, as an umbrella, maybe UIC as an umbrella, but put all of these disease specifics under that. So with one survey, with one work, we can bring all of these data together and then look into the end point again, which is the patient safety, which is the quality of care that we are providing to our patients. So a little bit of reflections from Pakistan government and WHO. Thank you.
Thank you very much. Thank you very much also to Anne, Ju, and to all the other panelists. Very good. So I think we're now hearing from the Francophone countries. Should we get people to switch over or just bring up the Francophones? So maybe whilst we're standing up, so that everyone wakes up, can you all stand up and sway? Woo! Wave. Also, if you're online, stretch, stretch, stretch. Thank you, Cameroun. Merci de venir ici. Thank you. Thank you very much. Please come. Thank you. Merci. Thank you, everyone, for the big applause for the panel. Thank you. Thank you very much. And also, thank you very much to Pakistan for being so concise and brief. That was brilliant. Cameroon, merci de venir. Merci. So, okay. So we have Cameroon, and then peut-être qu'on a le Togo en ligne ou pas? Do we have Togo online? Okay, we're hoping Togo might make it, but we're trying to get in touch with them. Bon, on commence déjà. Oui, mais je pense qu'on va voir parce que peut-être qu'ils étaient en ligne. Okay, great. So now we're going to have a point of view from the Francophone countries on the health information systems and data governance. Maintenant, c'est le tour des pays francophones. Et là, c'est le plaisir de présenter du ministère de Santé du Cameroun, Louis Richard Njok, from the Health Ministry of Cameroon. Thank you.
Merci, Samantha, pour la parole donnée. Comment améliorer le système d'information sanitaire dans les pays francophones, l'exemple du Cameroun? Je commencerai par dire que pour ce qui est du Cameroun, nous n'avons pas la prétention de sauter les étapes. Nous avons des objectifs réalistes. Je pense qu'il faut avoir des objectifs contextualisés en fonction du niveau de développement du pays, en fonction de l'architecture numérique du pays et de plusieurs autres paramètres. Bien entendu, le principal paramètre, c'est la priorité pour atteindre les ODD. Donc, pour ce qui est du Cameroun, les ODD ont été conceptualisés dans le système national, dans la stratégie nationale de développement à l'horizon 2030. Et en matière de santé numérique, la prise en compte de ce paramètre s'est traduite par l'apparition du cadre stratégique de développement de la santé numérique de 2020 à 2024. Et certains paramètres sont à améliorer pour l'effectivité de ce plan stratégique. Le premier paramètre, c'est d'abord d'améliorer la gouvernance. Il faut effectivement que le comité de pilotage prenne effectivement ses responsabilités et ce que le comité de pilotage qui est multisectoriel intègre la nécessité d'avoir un système cohérent de développement des données sanitaires. Donc, la gouvernance commence par la prise effective en main de ce comité de pilotage qui est multisectoriel. Ce n'est pas facile, chaque ministère ayant ses priorités, chaque ministère estimant que ça peut ou être facultatif ou pas. Donc, ça, c'est un défi majeur que le comité de pilotage, effectivement, puisse se mettre en place. C'est aussi un avantage dans la mesure où les données doivent être cohérentes. Il n'y a pas que les données sur le plan de la santé. Et donc, le défi de mettre tout ça en harmonie interpelle chacun des ministères concernés par ce qui est donné. La deuxième chose, ce sera de renforcer le dispositif juridique. C'est vrai que le Cameroun, il y a plus de 10 ans de cela, en 2020, a adopté la loi sur la cybersécurité, la cybercriminalité. Il va donc falloir aller un peu plus loin, notamment de façon spécifique sur l'adoption de lois protégeant les données personnelles. Dans les données personnelles, il va falloir y arriver. Mais il va aussi falloir noter qu'entre-temps, il y a eu quelques avancées, notamment l'adoption il y a 1 an de la loi sur la recherche impliquant la personne humaine. Et donc là, on commence à avoir arrivé quelques éléments de protection de la confidentialité sur la recherche humaine. Il va falloir aussi un autre défi, et c'est un défi majeur, dans un pays où il y a encore des naissances en communauté. Vous voyez que vous avez encore des naissances dans les communautés, et donc le défi majeur va être de capter ces naissances-là qui sont faites en communauté, donc qui ne sont pas naturellement déclarées parce que n'ayant pas eu lieu dans l'information sanitaire. Et ça, on le voit encore dans au moins 3 régions trois régions du Cameroun. Et donc, du coup, il va falloir dans ce moment mettre en place un système pour capter ces naissances-là qui sont faites hors des formations sanitaires. Et puis, deuxièmement, faire en sorte que le système national d'enregistrement des faits d'état civil, qui est piloté par un établissement autonome qui s'appelle le Bureau national d'établissement civil, faire en sorte qu'il y ait une synchronisation entre les naissances captées et la performance de ce Bureau national des faits d'état civil puisse être interopérable avec le système de collecte de données sanitaires, de façon à ce qu'on puisse y arriver. Il va falloir aussi en sorte de capter les décès et les causes de décès qui vont être notifiés entre les deux systèmes. Donc ça aussi, c'est un défi majeur. Et ce n'est pas le moindre parce que, comme je le dis, nous avons un contexte de développement de la santé communautaire pour pouvoir capter et pouvoir faire l'audit des décès en communauté. Il y a aussi donc, pour terminer, questionner un peu l'apport des partenaires. Il est fondamental, l'apport des partenaires. D'abord, ils ont un cadre de développement de la santé numérique. Donc, ce cadre de développement de la santé numérique est un cadre, vous l'avez compris, contextualisé avec des objectifs simples. Il va falloir que les partenaires prennent une place active dans la mise en œuvre de ce plan qui interpelle trois choses. Premièrement, développer l'architecture numérique. Deuxièmement, renforcer les capacités. Et puis, troisièmement, faire en sorte de les aligner sur les objectifs de développement durable. Parce que, encore une fois, nous avons rendez-vous avec l'atteinte du développement durable dans 7 ans. Alors, il faut absolument que si les données sont au service des prises de décision, il faut qu'il y ait un lien entre les données captées et la mise en œuvre de notre plan d'achèvement des objectifs de développement durable. Voilà ce que je tenais à dire pour cette séquence sur les pays francophones. Je vous remercie.
Merci beaucoup au Cameroun. Et là, s'il vous plaît, si le ministère de Santé du Togo est en ligne, merci de nous signaler, de soulever votre main, comme ça on peut vous donner la parole. Parce que, voilà, est-ce qu'on a le ministère? OK. Donc, vous êtes bienvenus si vous arrivez pour de commenter. Et entre-temps, est-ce que là, on a l'OMS du Togo. Est-ce que vous voulez ajouter quelque chose? Ça, c'est Salomé Julie Azamana. Vous voulez commenter quelque chose? Merci.
OK, merci beaucoup. C'est vrai que en tant que OMS, je prends assez aisément la parole au nom du pays parce que de bout en bout, on a eu à faire pratiquement tout ensemble. Et donc, l'OMS apporte particulièrement son appui technique et mobilise parfois assez de ressources pour appuyer tout ce qui est système d'information sanitaire au Togo. Et donc, j'aurais vraiment aimé peut-être qu'en dehors du ministère, il y a le HISP qui est en ligne et la GIZ aussi, Togo, qui est en ligne. Peut-être qu'après, ils pourront compléter et ce que j'aurais à dire. Et donc, parlant d'investir pour l'optimisation des données, honnêtement, le Togo a vite compris la nécessité de disposer des données de qualité. Et donc, déjà en 2013, il y avait plusieurs sources d'informations. Donc, quand chaque partenaire vient avec son projet, il met en place, comment on appelle, sa maquette de collecte de données. Et donc, vous avez pour les mêmes données des informations différentes, parfois inexploitables. Et donc, rapidement, le Togo a compris cet aspect et a vu la nécessité d'harmoniser les outils et d'aller à la digitalisation. Et donc, tout à l'heure, maintenant, quand vous demandez une information concernant un programme spécifique au Togo, vous aurez juste une donnée, juste la source d'information, elle est unique. Et donc, ceci s'est fait à travers la digitalisation des données et le Togo utilise le DHS2, ce que j'ai dit hier. Et donc, ça, c'est vraiment important pour le pays pour pouvoir orienter la prise de décision sur des bases factuelles. Et donc, cette digitalisation concerne non seulement les données de routine, pour pouvoir faire des statistiques démographiques, hein, oui. Et donc aussi les programmes prioritaires, donc le VIH, la tuberculose, le paludisme, et donc tout ceci est digitalisé. Et donc particulièrement même pour la tuberculose et le VIH, il y a des données individualisées et donc qui permettent même d'avoir du financement à travers le projet PEPFAR et autres. Et donc, un autre pas de géant, c'est la surveillance électronique qui se fait, la SIMR, qui se fait de façon électronique au Togo. Et donc, le Togo a aussi fait un pas de géant en matière de CSU, donc à travers le paramétrage des données de l'assurance pour les étudiants, les élèves et autres. Et donc, actuellement, le rêve le plus grand, c'est de pouvoir mettre en place un système d'alerte précoce. Et pour ça, déjà, je pense qu'on a eu un financement pour une année. Et donc, on espère avoir du financement pour les années prochaines. Et donc, bon, comme on me fait la main, je pense que je vais m'arrêter là en attendant. Donc, en réalité, tout ce qui est loi et tout est mis en place. On a un plan, on a un groupe technique pour la gestion de l'information sanitaire et j'en fais partie. Merci beaucoup. Peut-être que les collègues, Dr. Sili Adin du RHIS peut-être en ligne ou bien Monsieur Jacques de la GIZ, peut-être qu'ils auront à compléter. Sans oublier le collègue du ministère, Monsieur Ouro ou Dr. Théorie. Merci à vous.
Merci beaucoup à l'OMS Togo et bienvenue le ministère si vous êtes online de commenter. Voilà, so now thank you very much to WHO Togo, and if the ministry is online, you're very welcome to let us know and you can comment. So now we're going to move on to the geographic information system on why is it an equitable investment for health information systems. And we have Ravi Santana Gopala Krishnan, who's from the GIS Center Lead, DDI, WHO. And thank you for a concise and to the point presentation. Thank you.
Thank you. I'm actually coming from a family of 4 siblings, so I know what rationing means. I know already we are over time. I'll be very precise. I think they're going to, yes. What I thought is we are in the early stages of advocacy of GIS. So I thought I'll show some new frontiers where GIS can actually help in the area of health. So just on briefly about the center, we launched the center last year. So WHO launched a GIS center last year to help on 4 things. We are just connecting 4 things: maps, apps, people, and data. So this is our objective of our center, and we work in few other areas. But behind this, always there's a lot of people behind this, right? This is the team who's actually working. Actually, our team is very diverse. They are based in 20 different countries, 10 different time zones. So this is actually taking to our advantage. We are actually maximizing somebody starts doing a map in Canada and finishes in Fiji. We are actually utilizing this to our benefit. But actually, I'm going to show one example on how actually GIS could use. If you're not been well exposed to GIS, actually it can be used to count the number of deaths. Somebody asked me, is this really possible? It has its own limitations, but actually it is quite possible because GIS is an area which uses satellite imageries widely. Nowadays, you get everything without a mobile phone where you have the Google Maps and things. You cannot operate anything, right? You want to go from point A to point B. You're using this. It can be well used to do this. Imagine a country where you have cemeteries and there's no family burials, and it means it is possible to count even on weekly wise or monthly wise to know the number of dead bodies which is buried there. How do we do this? This slide looks complicated. This is just to prove a point that we know the subject, right? Otherwise, it's not that. But the point is on the right hand side for you is it uses satellite imagery. For example, we took a pilot of one small area. where we had some discussions of the COVID deaths and other things. So we took few cemeteries in that country. We took for 4 years of imagery, and we started analyzing. So we devised an automated process through which we could actually run a routine to identify or count. How does actually it look like? Might be with this good example of a dashboard, you can see that. So these numbers on the right-hand side, or when we started, there was already a lot of burial plots there, right? 2016 imagery, there were like 300 burial plots there. Then over a period of time, we checked imagery to understand. Definitely during the COVID time, there was a huge increase in the last 12 months of that period. It increased like 240% to the average of year-wise. So what does it say? Even though the statistics and things was saying different thing, but actually this proved, unless otherwise there's been a big accident or some big disaster in that place, or few of the burial plots are closed and everybody started using this. Naturally, there's limitation. As I said, there's limitation for this work, but there's also huge potential to know very quickly the number of deaths. That's one example I wanted to show. The next example is we jointly worked with UNICEF and other colleagues to design a digital microplan handbook. It might be new terminology. It comes actually from the polio world. Polio Eradication Initiative used this for long years and is well tested. Now it's being used for routine immunization and few other areas. What is the key in this? What is this thing is? More than 150 experts jointly work together to publish this book. So that, I think, rather than the book, I think that is a big achievement. Just to have so many people and bringing everybody together and pull a document of 200 pages, the biggest achievement here. What is actually we are talking about here? Microplan is simply like this. Before we are doing a analog or a simple microplan way, when we wanted to do routine immunization or want to do vaccination and other things, you call and you'll call an vaccinator and say, hey, what is your territory? How many houses are you vaccinating today? You vaccinate over a period of time, that becomes this operational area. Then we geospatially, we map them. From that, we move now into a digital space. Into a digital space where we use 5 components: satellite imagery, we use spatial population. It means where actually people live, because with the satellite imagery, it's very easy, right? You can find where people live. Then we find where the locations of health facility is. Then catchment boundaries of the health facility, because each health facility has its own catchment boundary, right? It might not be the same as the district boundary or administrative boundary, but you have your own catchment boundary. Then finally, drive time analysis. Within 15 minutes of my range from the facility, how much population could it cover? See, what is needed might be a mother has to take a child to the nearest health facility, either by walking or by some sort of transport. That's what we are trying to, what is equity is about that, right? So in that sense, you can find so many things, right? In routine immunization, we are using this for 0-dose identification. In polio, we used for a lot of accountability to know the denominator. This one was very, very effective. So I'm just going to talk about each of the components. Of course, I spoke about satellite imagery. Now we have fantastic satellite imagery. I don't know if you guys know, there's more than like 4,000 satellites up there in the space. Huh? It's more than what we think. I was talking with my son the other day. He said that, do you know Elon Musk has 2,500 satellites up there? I was surprised. I was thinking it was 10, 15 satellites. So much is out there. But the point here is, it is possible to have high resolution satellite imagery. What does it mean? It means anything more than like 30 centimeters is visible. It means if like 4 people we are sitting outside, it can be captured for this satellite. That level of precision, and it's publicly available. That's what it means. But what we're doing is, satellite imagery is just a picture, right? We need to go to the next stage of deriving vector, we call it as vector data. Deriving, here is the building footprint, where people actually live, where every household is. So we are investing some time and research on this area to mature that area, so that automatically you can identify how many people are living there. The next one is, this is widely used in many other places. Next we thought is, the bottom line is health facilities. The denominator in a country to measure anything, universal health coverage or something, is to know number of health facilities and where they are. So we started this initiative a year ago to know 3 parameters plus 1. The name of the facility, the type of the facility, the location with a unique code. So the challenge is this. Can we make this data set public in the ministry's website? The whole project is this. 194 countries. Can we make this public in the ministry's website? So as part of this project, nobody is going to collect data sets from external. We want the ministry to take ownership on this, ministry to drive this. That is the core of this project. That cube there is very nice. I really find it interesting. XYZ axis. X-axis is access. So we did landscape analysis of 50 countries to understand how publicly this data set is available. Score of 0 to 100. Is it available with email request? Is it available to a third party? It is available only for a few group of allied people. That is what we had measured. The y-axis is how accessible, how accurate, how complete, and how timely. Yes, I have a data set for my country, but it is 5 years old. I have a data set, but covers that sort of how accurate is the data set. In terms of locational accuracy, even in terms of names, are there 10 variant names for the same facility? So these sort of discussions, all the metadata, everything was done on that. The finally is the use case. You have a fantastic data set. You have it public. Who is using it? Does all the UN agency use it? All the multilateral organization use it? Does all the ministries use it? That is the core we are asking. This is the whole crux of this project. We have done 50 countries now, and it is done through a structured pathway. I will not go through this. We have shortage of time, but it is well done through this pathway. I think this is a good maturity model, which we are seeing for other projects as well. Through those structured pathways, for each country, we did the landscape analysis and we find some highlights. Finally, what we did is, this is what the final thing, right? Every ministry should be able to do this. To do this, what is the dollar they require? So now we have done for 50 countries, we have this number for each of the country endorsed by the ministry. So now we are going to the donor and saying, hey, can you support this country for next 5 years to make this project sustainable? Because they are already working, right? Like Global Fund, I know that they are working. Nepal, they've done a RFP for this. Gavi is supporting 4 countries in Africa: Sierra Leone, DRC, Nigeria, and Cameroon. So we like other donors to take this. Actually, this is a selling pitch. If you're a donor, please help us to pick your country which is of your interest. The dollar figure is not very high, but the benefits are very high. You'll make a big difference by telling the denominator to the world, which is very challenging right now. These are the partners. There are like 75 partners right now who are working with us. If you want to join us, please let us know, be part of this initiative. So the next one is, you know the facility now, you know where people are living, you know the satellite imagery. Now, the drive time. This is the most key for it, right? How much accessible is this health facility in terms of physical accessibility and in terms of other constraints which are there. This is my last slide. I'll finish with this. So this is how it looked like. Like, the beauty of GIS is beautiful maps. We have produced hundreds and hundreds of maps. This is one beauty here. In this map, it's like an interactive thing. This is like Google Maps. We want our challenger in this project is Google. So in Google Maps, I want to go from here to point B. You put it there. Our challenge is, you can put here any dot in this thing and say, hey, I want to put a new facility here. How much population it will cover? Or conversely, we were talking with actually Global Fund last year or something with the community health workers. Like, we are supporting 1,000 facilities. We want to scale down to 800 or something was the question. Actually, Nick asked the question from them. So which are those 200 facilities you will remove? Still, you will maintain your services. Or still you have an appreciation of your, or worth for your fund. This can answer. You can build scenarios here and analyze your existing service. I had an opportunity to talk to our Director General, Dr. Tedros, in one of the meetings. I'll finish with this, Sam, where we had the whole DDI department in this. There's one question we asked, actually. There's some commonality between McDonald's and a health facility. You know, what is that? Both of them do a service. Of course, McDonald's is a junk food. It's not a good example, but there's many chances we see that people bypass a health facility not noticing it. There's a lot of studies on that. The reason is it is not by choice, it is by chance. This is what we like to change, because a McDonald's never fails. When they put it, they exactly put it in a crossroad, in a cross-cutting place, and they exactly know what is the income of the whole group there. They exactly know how to retain their business. If they can do it, why not we? And this will definitely help us to choose which is your right location for your facility, where I should put my facility. Any country, this is a service for the Ministry of Health to say, hey, this is my current facilities. If I want to add one more facility, I will not just add blindly. I will use a good tool like GIS. Thank you, Sam.
Hello, thank you very much. Very interesting. Right, so without further ado, we're going to move on to questions. So can I see if you have any questions in the room? And otherwise, we'd also like to know from countries what you think partners can do to help with the investment in health information systems. So countries get priority, otherwise any other comments? Countries, please think of your questions, come forward, any comments, what partners can do? Yes, please. Let's give you a mic, sorry. Ah, pardon, Cameroon, oui, sorry, after you, yes. Merci.
Ok, merci pour la parole donnée. C'est un plaidoyer que je voudrais faire ici pour qu'on essaye d'améliorer la couverture géographique de la digitalisation des données sanitaires dans les pays. Parce que la couverture en énergie électrique, elle n'est pas uniforme. Donc, les zones urbaines sont plus favorisées que les zones rurales. Et également la couverture en réseau Internet. C'est pas toujours la même chose au niveau urbain qu'au niveau local, au niveau des zones rurales. Donc, il faudrait qu'on essaye de mettre à niveau les infrastructures pour qu'on puisse avoir au niveau des établissements de santé un minimum d'architecture acceptable, en plus du personnel et de tout ce qu'on a cité déjà ici, pour que nous puissions évoluer vers une amélioration de la qualité des données sanitaires. Voilà. Merci.
Merci. That was the difference between urban and rural areas. Any other comments or from, sorry, oh, yes, sorry, Cameroon, sorry, we'll just pass straight to Cameroon, yeah.
Okay, I'm going to express myself now in French pour partager, pour apprécier d'abord la qualité des présentations qui ont été faites, notamment sur le renforcement du système d'information sanitaire. La présentation qui a été faite par Xavier pour dire que le financement de la santé est un élément important, un pilier important du renforcement des systèmes de santé. Et la question que je me posais, c'est quel est, à votre avis, et là je m'adresse à Xavier et éventuellement aux autres panélistes, quel est, à votre avis, le meilleur point d'entrée pour le financement du système d'information sanitaire, puisque l'objectif est de renforcer le système dans sa globalité. Donc ça, c'est la question que je sollicitais votre appréciation. Pourquoi? Parce qu'au Cameroun, les comptes nationaux de la santé, ils décrivent les dépenses faites dans le domaine de la santé, montraient en 2019 que les financements extérieurs étaient la deuxième source de financement du système de santé. Et l'une des observations, c'était qu'entre 2018 et 2019, on avait observé un accroissement du financement de la santé qui était orienté vers les organisations non gouvernementales. On avait une tendance à l'accroissement du financement, non pas en direction du ministère de la Santé, mais en direction des organisations non gouvernementales. Or, c'est une tendance, en fait, qui pourrait, de notre point de vue, accroître la fragmentation. Dans la mesure où, et là je vais vraiment apprécier la présentation que Anne a faite, puisqu'à la fin, elle dit qu'il faut renforcer le leadership des pays dans la gouvernance des systèmes d'information. Ça veut dire qu'il faut davantage orienter peut-être les ressources vers là où on va avoir une vue d'ensemble des investissements également vers le renforcement du système de santé dans sa globalité. Et ici, le point que je veux mettre en exergue, c'est que le financement de la santé en lui-même passe par oui, le renforcement du leadership en matière de financement de la santé. Oui. Oui, donc la question justement, c'est ça. Quel est le meilleur point d'entrée du financement qui sont disponibles au niveau des pays pour renforcer le système de santé dans sa globalité? Je vous remercie. C'est ce point que je voulais mettre en exergue.
Merci beaucoup. Thank you, Cameroon. I'm just checking, is there anything, do we have any other questions from Pakistan or South Sudan or any of the other countries online? Sorry, just 1 minute, we're prioritizing countries. Any others? Sorry, let me see if there's... Otherwise, Anne, Ravi. Oh, yes, please, South Sudan. Yep.
Yeah, thank you very much, the previous presenters. I also have, I think, one question and then a comment. The question is really, I mean, we agree that there is that economic impact or return on investment on data, as has been demonstrated by the presenters. But we also know that resources will always be scarce, and so we must prioritize and probably sequence these investments. So I just wanted to appreciate from one of the panelists who presented on the economic return or impact on data, which components would we kind of prioritize first? So perhaps related a bit to the question from the previous presenter. Where do you start from? Or is there any framework that would guide countries on where you start and then you sequence your investments? For instance, when we look at the score, those dimensions, would you want to start with strengthening the surveys or the birth and death registration, or optimizing service data, or enabling the use of data for policy? So all what kind of framework or sequencing would you use that would contribute most to that return in investment and would probably have a knock-on or ripple effect on the others? Then I would also want to appreciate the presentation on the investment case for routine health information systems, and particularly at the peripheral level, the primary healthcare level, and the community levels. Besides its contribution towards improving quality of care, I think it's also powerful in addressing equity and reaching those who are left behind. Because if at the primary level, the health worker or the frontline health managers appreciate what is their catchment area, are able to collect data on those that have been reached, then on a periodic basis, I think at that level, you usually do it on a monthly basis. You're able to tally and know how many have you reached and then how many are left. And even the data that is collected at that level, of course, captures the location of those that you'll have served. So you'll then be able to actually pinpoint which parishes, which geographical areas are not being served. And therefore, you are then able to target your services in the subsequent period to those areas. And I think more important also is the community systems. In countries where probably the CRVS is not well developed, we know that there are traditional local systems where the local leaders, be they religious or even the community local leaders at village level, usually know the number of people their villages. And so it's important that those are also brought into the routine health information system, especially in terms of being able to determine those that you want to reach. So I think the linkage of the routine information system at the peripheral level, that's the health facility, the primary healthcare facility, with the community information systems will be quite critical in enabling us to identify those who are being left behind, and then therefore be able to target them with the services that require. So I think even as we thrive towards strengthening the civil registration of vital statistics, we see how it can be linked to the local and traditional community systems of being able to establish who are the people living in those communities, living in those villages, and who are being missed out by its services. Thank you.
Thank you very much. Just, did we have a complimentary comment from the South Sudan team? Sorry, just so we get you all at once. And then we have a question online from Bhutan and then again from Cameroon.
Yeah, thank you. And I equally appreciate all the presenters. I actually have to comment on two things and actually posed a question on what I think was reflected by Christian with regards to the routine data, routine health information system. There was that emphasis, which I was really very much impressed with regards to where the data is being generated by the health workers. We really need to echo that. The most important elements in data or in the health information system are the primary generators of the data, which are the health workers. Unfortunately, what is mostly being seen and being reflected, I can say it is taken by those who present the data, but those who generate the data are not seen, and what they probably go through, nobody talks about it. I heard him reflecting on the interaction between the health worker and the patient or the client, and the impact of that in the quality of the services. What about the quality of the data itself? Because when we are collecting the data or we are generating the data, and especially in the context of low and middle income countries where most of the data is still paper-based, there is a huge burden on the health worker who is attending to the patient, but at the same time, noting down the information that forms the data from the patient himself. In our context, whereby there is shortage of the health workers and use of the paper-based, we have seen a lot of data quality issues happening at that level, which I could not hear. And the fact that digitalization of the electronic recording might have contributed to some of those challenges, in the sense that we do experience a lot of duplication. For example, an outpatient unit, a client or a patient is attended to by the health worker and takes the personal information. The patient goes to the laboratory for the lab investigation. Because it is paper-based, a number of the same data or the same information is also required to be recorded because it's not transmitting. You go to the dispenser also gives or provides the prescription, but also needs to record a lot of duplicated information that is being captured, which we feel is definitely a burden on those health workers. And therefore, if there is a load of patients, it is easily compromised. You will see that services are being provided, but a lot of information is actually being missed, not recorded, and that affects the quality. The last thing which I also want to bring on to our attention is the fact that looking at countries like South Sudan, and I was looking at the GIS and the benefit of that, with my colleagues here, we are just whispering in our context, whereby how do we decide to put new facilities and the impact of the local context. I'm saying this simply because my colleague mentioned that yesterday that infrastructure is an area that partners are already shying away from in South Sudan. We look at the government with the economic burden and all the challenges that are there. It's very difficult, but putting up a new facility is an investment by itself. And the decision goes beyond the technical team. And in this context, is there a way that the GIS Center, beyond this meeting, can help on how best we can navigate locally to influence the decision makers in order to streamline the decisions when it comes to where the new facilities should properly be placed? Thank you.
Thank you very much. So Anne, I hope you're ready, and Ravi to comment. We just have one, I think we'll just take a couple more comments so we can amalgamate it. Okay, Cameroun, merci.
Oui, alors j'ai été très impressionné par la présentation de M. Ravi Santana. Et donc, du coup, ça me fait penser à des questions bien précises pour lui. Alors, la géolocalisation au service du système de santé, c'est très bien. Et nous avons, au niveau du Cameroun, géolocalisé les formations sanitaires dans le but de pouvoir arriver à déterminer les sites disponibles et de configurer la carte sanitaire. Sauf que nous ne maîtrisons pas la technique. Il me semble qu'il pourrait nous apporter quelque chose par rapport à cela. Et c'est important parce que quand vous voulez faire une planification efficace, on se rend bien compte que les routes sont impraticables. Il pleut, il y a certaines populations qui ne sont pas accessibles à la vaccination, il faut les identifier parce qu'il y a des montagnes, etc. On se rend compte qu'il y a des populations qui sont nomades. Il faut les capter avec le problème par rapport à la vaccination des perdus de vie, etc. Donc, cette technique-là est extrêmement intéressante pour nous, les pays en voie de développement. Il va falloir la mettre au service de nos pays. Deuxièmement, on se rend bien compte que la forme de l'État a changé. On est aujourd'hui dans un État uni décentralisé et que la gestion des formations sanitaires va être du ressort des collectivités territoriales décentralisées, les mairies. Il va donc rester pour le niveau central la définition des normes. Et donc, du coup, j'ai envie de lui demander, est-ce que cette technique-là peut permettre de cartographier les gaps, peut permettre d'identifier les différents besoins? Parce que si on identifie une formation sanitaire, on peut la qualifier. Est-ce qu'elle est aux normes ou pas? Et est-ce qu'elle a l'approvisionnement en eau ou l'approvisionnement en électricité? Donc, cela peut amener à définir un plan de contingence pour pouvoir capaciter ces formations sanitaires en énergie solaire, par exemple, de façon à ce qu'on puisse avoir une chaîne de froid efficiente. Donc, du coup, de pouvoir amasser cette... on ne peut, de mon point de vue, se passer de cette qui peut permettre d'identifier, de cartographier les différentes formations eau, électricité, chaîne de froid, infrastructure, équipement, et même le ratio, parce que si nous définissons la santé communautaire, un agent de santé communautaire, encore faut-il là. Et on se rend bien compte que pour les recenser dans le contexte de ce que j'ai dit, si c'est compté de façon physique, ça va être compliqué, alors que cette technique, comme il me l'a semblé dire, permet d'avoir le nombre de la population. Donc, on peut avoir des ratios qui sont efficaces par rapport aux besoins. Mais on peut aussi, on se rend compte que il est difficile pour l'administration d'aller à ce niveau-là, se rendre compte si les ressources humaines sont présentes. Elles sont parfois absentes. Pendant 3-4 mois, on ne peut pas savoir si l'infirmier a son poste. Est-ce que cette technique permet de suivre pour voir si, puisqu'on filme 30 cm, pour voir si un centre est en activité, c'est-à-dire que l'infirmier est là. Donc, du coup, j'aurais eu beaucoup de questions à poser à M. Ravi Santana. Merci.
Merci, thank you. We do have a break also where you can also ask your questions in person, but we're just gonna, I'm just gonna read this question also from Bhutan, then we're gonna hear from Pakistan, then we're gonna go to Ravi and Anne to comment on all these things. So we have a question from Bhutan online from Shering Wangdi. Would consolidation of all surveys in health be feasible, such as consolidating MICSs and other surveys, International Health Survey, which is conducted during a fixed period? And then Pakistan, did Pakistan still have a question? Yeah, please go ahead. Can you just give a mic? Thank you. Okay.
Hello.
Thank you.
Right.
My appreciation to the presentation on GIS and Google-based mapping. And my question is is there any evidence of conducting such mapping through GIS Google-based technology with the key population for HIV, that is female sex workers, transgenders, and the people who use drugs, things like that, key population for HIV? Is there any example? Can we do that in far-flung areas?
Okay, sorry, I'm just checking if we have any other countries. Sorry, it's just, okay. Sorry, Craig, was there any other country that we, okay, for the time being, we do have time. Sorry?
Can I have a question from Burgess?
Yes, sorry, if you just compliment, keep it brief, thanks.
Yeah, in my previous job, I used to work a lot on the DHS census mix and all of those. And the way that it's globally, basically, we are moving is that more moving through the administrative data, even on the census and all that, rather than the routine 10 years one. So I see the same trend here when we are talking about moving more to the RHIS health facility as, data rather than the surveys and how that would help. And again, the presentation in the morning was really, really helpful on that. Now, my question would be that when you go to the health facilities in many of these countries in the remote areas, you will see a lot of problem with making things electronically, collecting the data. Apart from the interaction between the health worker and the patients, there are practical issues on the electricity. Many times it's not there. The IT support, that is not there. I mean, I'm sitting in WHO country office and every week I have several times calling my colleagues, IT colleagues to come and help me. And so you can imagine how that is going in the health facilities. And then in the staff capacity that was mentioned a lot. So practically, when you go to the system, there should be some kind of, I don't know, balance between the paperwork and the electronic work. And at one point, maybe it's for some facilities, you have to have the paperwork done and then sent to the higher level to consolidate it. And then, of course, analysis on the higher levels. So that is a issue that I would like, especially Xavier, to reflect. Thank you.
Okay, great. Thank you. And also, as we heard also from Cameroon and South Sudan, we're talking about vast distances in many countries and very difficult terrain, which makes it even more challenging. So, Anne, I think a lot of the questions have come to you. If you'd like to start, please. Thank you. Or Claire, sorry, Claire. We'll get Claire, then Xavier, and then Anne and Ravi. Sorry. But you will all answer.
Thank you. No, thanks very much. Really interesting set of questions. A lot of them very technical that I will not attempt to even mention, but particularly wanted to respond to the comments on the investment case, and particularly the really good question from the colleague from South Sudan. I think your question really exemplified the ways that these different pieces of work really well together. And I think, we're not sort of looking at competition between pieces of work, but instead thinking about how they really complement each other and can help to speak to different audiences. Because I think that the point of the kind of investment case work with the big numbers that suggests, these very large return on investments, obviously opens the political door. It's not intended for technical audiences in ministries of health. It's intended for audiences in ministries of finance, in the big financial agencies. And it's those pieces of information that which open the door that we have so far failed to open, frankly, in the data space, that open the political door through which you can then walk with these much more detailed and substantive pieces of work that speak to particular systems, the particular impact of investment in very particular ways in the specific political choices that need to be made in each country. So I think it's helpful to think about these as complementary pieces of work intended for different audiences, for different purposes, that will meet different needs in the very complicated political environment, which we will all need to navigate if we're going to achieve our ends here. So I think your question exemplified that perfectly. And I think is exactly the way to think about these very complementary pieces of work. Thanks.
Thank you. And can you pass the mic to Xavier, please, and then back to Anne? Thank you.
I already have a mic, thank you. Je vais m'exprimer en anglais parce que c'est plus facile, je pense en anglais maintenant. So, yes, I think addressing your issues, I think there are 3 entry points. One of them is the granularity of how we look at health information system. This is an observation that our health economist, Donella Besada, has made us ad nauseam. So really, we have to look at the detail of the system. We have to look at the forms, at the processes, at the flows, in order to really understand where are the mistakes and remove them. If you've seen the video of Botswana that preceded our presentation, the first image was a health worker with a register book that is a table. For God's sake, do you think that health workers need a table? What for? I have to say, coming back to 1 second to South Sudan, that the government of Catalonia in Spain, well, in Spain, not sure, but the government of Catalonia has issued a recommendation to stop bureaucratizing health services and healthcare because they have realized that this is really reducing quality of care in the country. And they put this in a regulation and based on the ontological principles. So, yeah, the second entry point is the issue of human resources. We have to be aware that all these millions of hours that they are used, ministries of health and directors of health services, they think that this is time that they are using for healthcare. And no, this is time they are using to fill in forms. So actually the costs, even if you don't pay directly for this, but actually you are borrowing, the health information system is borrowing cost from the provision of health services. And the third issue, I think that, which is the difficulty with all the routine of investment cases, is that when we look at the potential economic benefits, the relation is not linear. It's not like you go to buy a sandwich, you pay for it and you get the sandwich. When you invest in quality of care, the returns will come in the GDP and will come through other channels. But there is overwhelming evidence and more that there is quality of care can really, there are a lot of deaths that can be amenable through better quality of care. And this results also in economic gains. So if we can show, as I think we can show overwhelmingly, that the health information system, the routine health information system is a quality of care tool, what you are saying is that there is some contribution that even if it is relatively minor, if you wish, has an exponential impact on economic benefits. But this, as I said, this is not something that you get the next day in a shop. I just want to, I just wanted also to, because I have here the routine health information system tools of Nigeria from 1997. You wouldn't see hardly any difference, certainly not on design with the current tools. This is 25 years ago. And if you go and you see the digital tools and going back to the issue of paper and digital, our designers, we know very well them because we have been working with them for 6 years. Our designers tell us that the issue is not the technology, the issue is the approach. How do you design things? When you see many of the digital tools, they don't have even a visual language. They have basically ODK questionnaires put in a tablet where you have to enter information. But what is that? I mean, this is unethical. I mean, we have knowledge, we have tools to do things that are user-friendly, that are easy to use, and they are there. The only thing is that we are not looking at this. Thank you.
Thank you, Anne.
How much time do I have?
This time your answers are very needed, but concise. Thank
I
you.
think we can continue this discussion because what has been brought in this conversation here is actually, that is the objective of these sessions. We would like to have discussed more, but this is going to be continued over the break, over lunch, and through the other day. But I think just there's lots of similar questions and comments, and I'm just going to summarize it in here. Investment in health information system. I think it's a lot of the required data, and in the yesterday and until now, we've discussed it's a lot about reporting. We look at the SDG, we look at the USCs and some of the quality of care. But then maybe that is where we start. We started where we want to go. And then from there, we will see, look at the framework of the score. We have the primary data collection tools, which is the S, the C, the O. We look at how we're going to collect the data from the population-based perspective. We want to understand our population through the census. We want to understand how we respond and monitor and survey the risk, the public health risk through the surveillance. We wanted to know about the cause of death, the birth, where they happened, and what are the causes of death, and how does it contribute into the census population and overall, and how does it disaggregated at the subnational level. We want to know at the facility, at the community, what has happened there in terms of the number of people coming in terms of the disease they're coming to for the services, in terms of the readiness of the service, in terms of the logistic, the finance, the human resource. And then we look at that and see what are we going to do with them. And then that we need to compare it to something, which is the M&E framework. And I mentioned earlier, we need to have we don't need so many different M&E framework. There should be one M&E framework that cover the SDG, the USC, the national targets, and the program core indicators. And from there, we work and we see how we're going to prioritize that. What is your country priorities? Is it MCH program? Is it immunization? Is it communicable diseases? Is it non-communicable diseases? Are we go beyond that and go into more complex issue like climate change? All of that would be reflected through your framework and through the SDG and the USC. And then we work backward in that ways, and then the enabling part will look at the structure, what is required for all of that put together. And one core thing is we look at the data use at the end. It's not what we report, it's not what we collect, what we use the data, why we need this indicator, what we use it for, and who are our target audience. If with that you make all the data visible and the analytical products of that visible at every level of the health facility, not just to the parliament, not just to the minister, not just to the donors, to those who collect the data. And if we have a system that enable that, which is going through the interoperability, the integrations, and have that and help people to plan to respond to the needs of the community and of the population at subnational level. By that visibility of the data, we also show the gaps. And I think the gap is where we need, because that is where the investment have to go in. And I can say immediately it's infrastructure, it's human resource. It's about the capacity of the people. We don't have enough people. That is most common. The data of the quality is bad. If we don't use the data, it will stay bad. If we struggle with it for a while to use it and stubborn about it, it is going to be improved. There is a lot of tools out there to help us. So the investment would go from that framework of M&E, go into your country priority with the programs, and the score will help you to identify where the gaps are. And then we have a tool for costing tool. We have a tool to monitor that. We are going to have a strategy that I hope by the end of this year will be out there with all the available tools. And then we work from there to see how we work with all the partners and support the ministry and implement that plan, and then build the capacity for that. So I think we can continue this discussion for the rest of the day. Thank you.
Thank you very much. Now quickly to Ravi, and then we're going to have a break. Thank you so much.
just like Anne said, I think this discussion, we can have one-to-one discussion for most of the question asked on GIS. Quickly on 3 points. One on the question about like the poor infrastructure and the challenges. Actually, GIS can be a great advocate. We can clearly pinpoint which is the connectivity issues in which facility, what are the challenges, and put them in a map. Why I'm saying this is in DRC, when we had the polio outbreak, we mapped the refusal population for polio vaccination. The moment you brought them into a map, it gave a tremendous change. It is every village might be just 5 families, 6 families, 10 families. But the moment you start grouping them, and then you say which church they are associated with, so that you can start doing the advocacy. So UNICEF really used that a great way once we started doing it spatially. Let's start thinking spatially, it will help us. The same thing for Cameroon. The federal and the local level, there's always going to be this tension. If you're more clear with your data and your advocacy, GIS can definitely help. Where if the central government tells that this is where you have to put your facility, you can challenge them through a fact or through an analysis saying that this is not the right location. Rather than saying that just through words and things, you can actually do it through a spatial map. I stop there. Thank you, Sam.
Thank you very much. Okay, break time. Thank you. Big applause for everybody.
The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities.
Yeah. Okay, so thank you all. And the point of this session now is to really open up the conversation. And we're going to be looking at advocacy and action to invest and improve health information systems in country. So we're going to start with Kirsten Matheson, Transform Health, who's going to get us all thinking and moving.
Let's wait for the slides. Great, thank you. So we've heard a lot over the last day and a bit now, not quite day and a half yet. This session is very much about how we move from a lot of these conversations that have been happening and how we look looking ahead and what's the action that's needed, how we can all work together to drive forward some of these areas of work. So we're gonna I'll start off and then over to Craig to present some options for a way forward to start us off for the conversation. And then we can see kind of how we all work together and take it forward. So just to kind of bring us back to where this meeting comes from. So starting from the Health Data Governance Summit in 2021, where there were a lot of important discussions, the outcome statement that really called for commitment, recognized the importance of high quality data to inform policies, budgets, and plans, and called for a global framework and good data governance practices underpinned by global unifying principles. But how we now move from those discussions and those commitments and all the discussions we've been having here today to really look at concrete actions over the next year or so. How we can improve investment in health information systems and how we can strengthen health data governance. So just a bit of a recap on some of the things we've heard over the last day and a bit. So really, I think we can all agree, and it's why we're all here, strong recognition of the importance of data as such an important tool to help improve health outcomes and really to drive our progress towards universal health coverage and our SDG goals, and the need to prioritize investment in health systems and health data governance. We've heard a lot around issues around the need to strengthen health information systems. So lots of issues coming up around, siloed approaches, issues around interoperability, integration of systems, need to reduce duplication and fragmentation, lots of multiple parallel and fragmented stakeholder systems and investment. And the need to strengthen data collection and monitoring to really improve the availability and quality of data, capacity issues that have come up, infrastructure, data utilization and analysis, and really strengthening data-driven policy. Around health data governance, we've heard a lot around issues of data protection, facilitating data sharing for public good, addressing also kind of fragmentation and non-alignment of regulations and standards, how we can facilitate cross-border data sharing, and the need to govern data collection and use of all actors within countries, and the need for stronger regulation and health data governance frameworks to really build better health outcomes and trust in data systems. We've also heard a lot about needing to make sure that governments are in the driving seat as we lead this work, and that partners are investing and supporting and aligning behind those government efforts and those government priorities and strategies. The need to really ensure multi-stakeholder collaboration, partnerships, really strengthening partnerships, and ensuring we're having inclusive approaches around this work. And also, we've heard a lot about really learning from what's happening in countries, good practices, learning from the good practices, but a good point was mentioned yesterday, also learning from the challenges to understand what's needed and how we can advance those efforts. The importance of having really people-centered approaches, realizing the communities are ultimate stakeholders and need to be central to design, being consulted, part of governance structures. A lot about equity and rights really being at the center of everything we're doing, and then also the need to really ensure we have sustainability and sustainable solutions. So that's what we've heard. And now, what can we do about it? So the first proposal, which I'll put forward around health data governance, then I'll hand over to Craig to talk about proposed way forward around strengthening health information systems. So what we're proposing is recognizing the need for kind of stronger regulation, health data governance frameworks, and the alignment around regulatory standards. So proposing the development of a global health data governance regulatory framework, which with governments in the lead that could then be adopted at next year's World Health Assembly by member states through a World Health Assembly resolution, but seeing over the next year, building from the momentum from this meeting, how we can work together to develop that framework, really driven by governments, as we've all agreed, need to be in the driver's seat around this, but also pulling on the support of WHO, the Health Data Collaborative, and other partners to help facilitate that process on behalf of and together with member states to develop a framework. And again, just reiterating that such a framework would then help really build country consensus and alignment around those common regulatory standards to then strengthen national legislation and cross-border data sharing. And also just really ensuring that such a framework is developed through a very inclusive, transparent, multi-stakeholder process. So how we can, governments in the lead, but also work with other stakeholders to inform and input to such a framework. So just in terms of how we can get there. So I think this meeting is a really important opportunity to kind of kick off such a development of a framework, as well as at next week's World Health Assembly, where there'll be a lot of important discussions and where member states come together to discuss what are some of the priorities that are needed around a lot of these global health challenges. So how we can leverage today's meeting and next week's World Health Assembly to really kick off some of that action and to lead to concrete commitments and action to take that forward. And then over the months ahead, then to really ensure we are driving progress in developing such a framework through, leveraging different moments and opportunities to discuss what needs to go into a global framework, to consult with different stakeholders, to bring together governments to discuss what the needs are, and to really use some of those moments as well to build up some of that political support, to build that consensus and to gather those inputs. And so, yeah, I'll in a second share some ideas of some potential upcoming opportunities that can be leveraged for this. But then if aiming towards next year's World Health Assembly, October being quite an important moment to then for governments to propose items for next year's World Health Assembly. So making sure that we are then building on that and putting those proposals forward. And then at the executive board meeting in January, putting forward a potential resolution that could lead to the adoption of such a framework. Just a few points in terms of kind of approach around developing a framework. So again, making sure that it is guided by and underpinned by a lot of those principles we've talked about, such as the health data governance principles that have been launched and endorsed by over 140 organizations, ensuring that this such a framework, it's not starting from scratch. There's a lot out there. So really complementing and incorporating existing duty obligations that governments have already made, as well as other global standards, to really learn from a lot of the good practices, good data governance practices that are out there. So VCAS presented a number of them yesterday, a lot of work happening in different countries. So how we can all really build and learn from those in the development of such a framework. So it is very much a bottom-up process. Learn from the existing landscape as well of what's happening, principles, tools, what countries are already doing. Again, that inclusive consultative approach to bring in, not just for the sake of bringing in voices, but to really learn from the perspectives and expertise and what's needed around it. And then also just really leveraging the guidance of different experts in this field around data governance, legal experts, et cetera. So just quickly, and then I'll hand it over to Craig, some opportunities over the next year or so that can be leveraged as these convening spaces to bring together governments and different partners to discuss this and to really kind of track and make sure we're making progress. So obviously next week, the World Health Assembly, a really important one around that. For those of you that will be in town, there will actually be a side event. I mentioned it yesterday. There'll be a side event on health data governance that's co-hosted by the Ministries of Health of Cameroon, India, Sri Lanka, Maldives, and the Philippines, which is focused very much on this issue of building up support for stronger health data governance and a global framework. So do encourage you to join. It's on the 24th at the Intercontinental Hotel. Then following the World, and really hoping also as well that during the official proceedings of the World Health Assembly, how member states can raise these issues. So it's heard and echoed by others and kind of building up that demand and the call for WHO to support such a process. Then following that, there's a few other opportunities. There is the SDG Summit in September, the high-level meeting on UHC, the World Health Summit, numerous regional and national gatherings that can really be leveraged around this. We heard yesterday as well about the AHIN, the Asia eHealth Informatics Network, that's organizing a consultation later this year to bring together governments in the region to discuss these issues. But also leveraging things that are already on the calendar, but also creating spaces for those discussions and dialogue as well. And then in addition to some of these moments that are happening, there are a number of initiatives and processes and existing mechanisms that can also be leveraged to have these discussions and consultations and build that consensus. So of course, we know the Data and Digital Governance Working Group of the Health Data Collaborative that has this as a priority as part of their work. The Africa CDC Digital Transformation Strategy and their flagship initiatives. That's a really important opportunity to discuss health data governance issues and the need for stronger regulation around it. The G20 process, as we know that they had been talking about health data governance within the Health Working Group, the Global Digital Compact and the upcoming UN Summit of the Future next year as well. Another good opportunity because a lot of these issues are coming up as part of the consultations around the Global Compact. And so these are just some of them. There are surely others, but there are a lot of opportunities that can really be leveraged to make sure we're continuing those conversations and then we don't wait to meet in 2 years' time to see where we are, but hopefully we will have already made that progress. So now I will hand over to
Thank
Craig.
you. Sorry, we're just checking. Is Victoria online? Not yet. Okay. Craig Burgess from WHO, if you want to carry on. Thank you.
Thanks, Kirsten. I've only got 2 slides, I promise, but I want to kind of just go back to what Kirsten reflected on. What brought us here in the first place? It's building on the foundations that were laid in 2021, when many of you were present in the Data Governance Summit. What did that summit actually produce? It was a publicly available statement which said, making the case for data being a global public good and of course a strategic asset by doing 2 things. Investing in health information systems more efficiently and better data governance. And that's really the reason that's brought everyone here today. What I'd like to do just now is just go and complement what Kirsten has done on the data governance side and the advocacy side with here are just some tentative proposals on the way forward in the next 2 to 3 years. And we want your response to that. We've especially asked Malar and Zen to reflect back, but these are just a tentative proposal for you to think about. What we're proposing, first of all, and I think what we've heard loudly, not only yesterday and this morning, but over the last couple of years, is we need to be as country focused and country driven for a whole range of reasons: ownership, sustainability, responsibility, efficiency even. A country focus as possible. We're proposing that in the region of, we're suggesting 26 odd countries by 2025 in that region, that potentially we're using SCORE as a framework to strengthen health information systems. So both Steve referred to SCORE in his opening remarks, and Anne has had an in-depth presentation on what SCORE is. And just to remind you, I'm just going to just flick one. And yeah, just to remind everyone what SCORE is. Remember, it's not only an assessment tool, it's actually a way of looking at health information systems for a suite of potential interventions, and at the end of it has a potential policy dimension to it and funding dimension to it, with the R and the E of SCORE, through partnership in countries led by countries' ministries specifically. So what we're proposing is that under under SCORE, you have an element of CRVS, which Anne has described. And if you look at SCORE, the vast majority of countries, the weakest part of SCORE is CRVS, Civil Registration and Vital Statistics, which has got a large dimension of equity to it. If you're not counted, there's a whole range of, as we've heard from Anne, a whole range of rights and equity-based issues surrounding that, as well as death certification as well, looking at mortality statistics, etc. So I just want to draw your attention to what SCORE was. I just want to go back one. So what we're proposing is using SCORE as a framework, which is what you've heard, as a potential way of investing in health information systems. It's not only an assessment tool, it's got a suite of potential interventions within that, including surveys. So we heard very strongly from countries the huge number of surveys and reporting burdens. I think Claire had a great quote this morning from just how many surveys were happening in one specific country, and what inefficiencies, whoever's investing in surveys, happens, and the inefficiencies of reporting burdens by countries of having to do that. So within that, maybe there's a possibility of consolidating the way in which surveys are looked at. And I think we'll get into that discussion this afternoon. What we're proposing is that with a country focus at a time that is aligned with country planning cycles and budgeting cycles, that partners come together when countries need in the countries to look at the health information system dynamics and needs, and most importantly, gaps to be plugged. There might be technical gaps, there might be financial gaps, there might be political gaps, but really aligned a lot more with country planning cycles over the next 2 to 3 years. And that partners together, we're suggesting possibly using the SDG 3 gap or the Health Data Collaborative, but whatever platform is working most effectively in countries, we use that as a platform to strengthen country health information systems for health outcomes, of course. That's what we're suggesting. We'd like your feedback on that. The second thing that we're suggesting is we heard loud and clear the issue of capacity. It's a concept that is banded around frequently. It's ill-defined sometimes, and sometimes in the discussions we get confused. But what we're hearing loud and clear from countries again is there is a need for specific elements of data analysis and use. That seems to be, from where we're sitting, the two weakest part of kind of capacity. What do we need to do? Do we look at in-service training? Do we look at pre-service training? And how can we use regional and national institutes to build up the capacities of countries, of regions, to deal with the analysis and use of data? We heard from Xavier this morning the real need of analysis and use for data at the front line. Think of a healthcare worker, think of a district manager. The capacities are needed. They need increased, certainly for analysis and use. The third thing that we're suggesting is, and I think basically it's building on what Kirsten and colleagues have said already and what Claire said this morning, is building up the momentum. As Claire said this morning, there's never been a political opportunity quite like this. And we need to, all of us in the room and partners, I think we need to kind of seize it. It's an opportunity that in my lifetime anyway, I haven't seen quite so much focus on the need for quality data and the issues surrounding what constitutes good quality data. So there's an opportunity. Can we look at advocacy that Kirsten has highlighted at the political level and within the World Health Organization and within the WHO? There's a range of different things that are happening in the next 2 years that we need to kind of work together in partnership. There are political events. Can we get our common messaging right without being too fragmented and approaching the same people with very different messages? Can we work together on the key messaging of exactly what needs to happen for health information systems, but also data for the SDGs. And lastly, we'd like to kind of pick up on making the case. We heard from Xavier this morning, colleagues, and also Claire this morning, about making the social and economic case for data being a strategic asset. That's not just health. We've discussed it already. It goes beyond health. How can we work beyond our silo? Even within health, we're all siloed, and health is a silo in itself. How can we reach out and work with other colleagues to make the social and economic case for data being a strategic asset and a worthy investment by countries and by donors as well? And that requires thinking out the box and changing the way that we do things and making sure that we're very much aligned with the SDGs, of course, but looking beyond our own ministries of health to national statistics offices. How can we work more collaboratively with national statistics offices? So I think the last thing I wanted to mention was just moving forward in the next 2 or 3 years is looking at how do you want to use the SDG 3 GAP platform or the Health Data Collaborative as a potential partnership way of strengthening countries and the coordination in countries and globally getting the messaging right. It's your platform. It's not, I mean, we're the Secretariat, it's your platform. How do you want to use it? We think it's got potential. You might have a different view on that. And remember, there's an evaluation of the HDC that will be released in September. And we want to be a lot more solution orientated. So that was it kind of in terms of next steps for HIS, really building on what Kirsten has been saying, but we'd value your thoughts from CDC and World Bank on that before handing back to the floor. Thanks, Samantha.
Thank you very much. Okay, so we're going to move to the World Bank and CDC if you have any comments. Thank you.
Yeah, thank you, Craig. And thanks just not only for the opportunity to participate here, but putting together a really rich combination of skills, that technical skills, but also leadership from the country level, and for the candid and sometimes provocative discussions, which I was happy to participate in. I just want to briefly highlight a couple of things that resonated with me during the course of the session. First, I think in the opening remarks, our colleague from WHO remarked that, you know, we're not listening to countries, and that it's a reminder that that really needs to be a key focus. We heard that many times repeated during the session. And from the country teams, fairly consistent feedback about too many disconnected systems, duplicative efforts, disjointed donor support. I think one of our colleagues characterized it as serious chaos. And what do we do about that? Several people commented on the need to think about the costed models and the need to focus and to make the audience the ministries of finance, not donors, in these discussions, or at least in addition to. A lot of discussion about guidance needed about how to guide investments. You know, the HIS landscape is actually quite complicated. How do we make sense of it? How do we plan for it appropriately? How do we make decisions about things like open source versus proprietary? How do we prioritize? Is there a framework that's available? All of this, I think, ultimately relates to the need for enterprise architecture, and strengthening the planning for systems such that we have an overarching framework that has gotten good shared vision that will allow us to make strategic choices about what to fill in that framework first. So when is it appropriate to, to work on the clinical systems, the routine health information systems, and then how do we make effective decisions about what tools are really fit for purpose, that they're robust enough, that they've got the cybersecurity considerations, that they're scalable, that they're affordable, that can be supported with resources that are available, including building up the human capacity where it's needed. I just want to close with one analogy that just struck me, the side road analogy. You know, when we're having to keep our health systems afloat, we need to continue data systems even if they're weak. And that sometimes means we need to take the side roads in order to maintain that operational integrity. But we still must focus on funding the main roads, because ultimately that's what's going to get us out of this chaos. So I will use that analogy further. Thank you.
Thanks, Zen. I wanted to also start by really thanking the Health Data Collaborative. I think this is my first experience being really engaged with them, and also the Secretariat, Craig and Carolina, and also amazing colleagues for such rich discussions over the last 2 days. Thank you very much. I will not repeat what my other colleagues have already said here. Maybe I will highlight some of the things that stuck with me from the discussions over the 2 days. I think the first is we have to stop treating this as a technology problem and have really laser-like clarity on the health problem that needs solving. The second is we need to have a relentless focus on taking a digital and health approach that can scale. So we move away from pilots, that's integrated, but also it's incremental in nature, because it's a huge agenda that we are talking about. So this actually goes back to the point that some of the colleagues from South Sudan made about how do we sequence reforms, especially under the current fiscal issues that everyone is facing. So how do we do this? So taking an incremental nature, having an incremental approach to this, to the digital and health approach, but also taking into account country context and the country's digital maturity. So there's no one blueprint for solving this across country, but how do we adapt some of the best practices to country context? I think Maldives also, really made a great presentation again on their approach of how they built a digital health blueprint, and they're taking an enterprise approach to solving some of the digital health issues that they are facing. And the third is not losing sight of the foundational issues that still continue to exist. So fixing the foundations like infrastructure, health data governance, digital literacy, technical capacity. So really making sure that we continue to fix these foundational elements while we're getting prepared, or we start embracing the frontier technologies. And then also looking at more cross-sectoral coordination. More and more, a lot of these digital systems are not just going to be integrated within the health sector, but they also need to be integrated across sectors, say both digital and data. And evidence of what works and what doesn't work. I think many of you actually kind of raised this, and maybe in implicit terms. I think it's important to understand that. But it also touches upon the knowledge sharing, understanding what is working where, and it's great to see a lot of the work done by HDC around that in terms of documenting best practices and sharing what countries are doing well. We have Transform Health, we have the Claire here from GPSSD. I mean, I think there's a real opportunity here to connect all of this learning that we have from these communities. I also wanted to share that the World Bank also runs something called the Joint Learning Network. This is actually a country-led learning environment, and they've started courses on digital health. If anybody's interested, we're happy to share information on that as well. And then this is a point that the Pakistan colleague here actually raised about sensitizing leadership around the importance of investing in digital and data, again, in a sort of fit for purpose manner. This is, again, links back to Claire's point about opening those political doors. I thought it was just great to hear it from very different perspectives, from the government, but also from you, Claire, from a civil society perspective. And finally, I think we have to bring everybody along in this process. So it's really important to have trust and value be clearly defined among the healthcare providers and patients, so that they see the value of technology and data, and then they can trust in the technology and value that that is in the process of improving health and healthcare delivery. I think that the last point, I want to connect that to that user-centered design. I think colleague Xavier said technology is not the problem. It's really about how we are designing these approaches and the business processes that are involved. Thank you.
Thank you. Mic problems. All right. Hi, thank you so much. Okay, great. So now we'd love to hear from you in the room, how you think we can move forward with this advocacy and action, especially obviously starting with the countries. So I'm going to stand up so I can see you all. If you're online as well, please let us know if you have any comments or questions. So what do the countries think? Do you think we can go to the World Health Assembly next year, or what is your view on all of this advocacy moving forward? Come on, countries first, sorry, and then we'll come to WHO. Thank you. Yeah, South Sudan. WHO. Okay, do we have any countries? We love WHO, but we want to hear first from the countries. Cameroon, qu'est-ce que vous pensez de ça? Right, so maybe we will have a comment from WHO. Or did Cameroon want to comment? No. Vous n'êtes pas sûr encore de vouloir faire du témoignage là-dessus? Okay, online. Who have we got online? Sorry, we have online. Very good. We're going to give everyone a moment. Just a sec. Just going to find it here. Online. Lena. Sorry. Anyone? I can't see who it's from. So sorry, any other comments then in the room? We'll start with a comment in the room. Sorry, we had first over here. Oui, voilà. Merci. Thank you.
Merci beaucoup. I think we have learned a lot in these 2 days. Not only this issue should be tabled at the World Health Assembly, but I will also advocate that subsequent to this, it should also be discussed at the regional committees. So it's unfortunate that our regional colleagues are not here, but I will make sure that in my report it gets to them. I will advocate that after the World Health Assembly in May 2024, the regional committee of the African region should discuss this issue so that the advocacy, actually I have been thinking that this is true, a high level meeting, but it can go higher. And so I'm coming from the map of Uganda yesterday. And that situation, what is interesting is to know the transformation that is going on in Uganda to make sure that their health information system is transformed and it aligns with the change of paradigm that we saw this morning. Because for me, the main take-home message is really the change of the paradigm. I mean, I have been in this game for quite some time. I don't know who remembers Mr. or Dr. Stephen Lwanga. He has been here in headquarters, supporting the health information system development in our countries. He came to Botswana to just support the health information system 25 years ago. And what we are seeing, yes, there have been progress, but there is really a complex change. We are in a different world. And someone said that you cannot apply good governance on the bad system. So for me, the key issue is how to advocate to the high level political leadership, ministers of health, ministers of finance, to really say that, like it was said this morning, that when you invest $1, you have $32 as return. We need actual evidence. If that evidence can be shared in the chat, that would be useful also for us to advocate for. So I mean, this has been terrific, but remember, we are a group of activists, advocates, but outside there, the ministers, they have other issues. So we need to find a way of really attracting their attention and say, this is the way to go. You will not achieve SDGs if you do not invest in this area. You need to know what is the situation in your country and all the tools, including GIS, that have been presented to us. If the ministers of health and finance do not capture the needs, we are lost. We still have 25 years to go. But if really they can believe in this change of paradigm, then I think the reward will be extremely useful. Thank you.
Yeah, go ahead.
Thank you very much. Yes, I agree that should take this to the next level, the World Health Assembly 2024. But we must be organized in ourselves and not start organizing ourselves after the World Health Assembly. So by the time it's taken there, we know exactly, must almost be prescriptive. And I agree that let's target the planning cycles and the budgetary cycles. That's where we need to go. Whether it's the countries are doing 3-year expenditure frameworks, we should be there so that in that 3 years expenditure framework, the health information systems are a budget item and planned for and money put aside. I think that's so important now when it comes to partners, because I've been in situations where partners employ their own data capturers, place them in a health facility, train them to collect their particular program data. And then it's like when they're done with them, they have to leave the system. But they are part of that health facilities, health information system, the district health information system. But if we have a government that has already planned for that human resource, it's much easier to take them over and continue. So it will also take us away from disasters like that. I also of the view that if we then bring it to the expenditure frameworks, it's where all the ministries sit together. It's not just Ministry of Health. So let's do things differently and let's go there where we get these kind of changes that we're looking for. Thanks.
Thank you so much. I'm just going to read out a comment online from Lina Sahade Convidado. Thank you for the session. It really opens a new approach. I would like to ask if countries can develop and monitor and evaluate, also to follow up on the performance of the trained health workforce on how, what, and when to collect or analyze data on a country level and global level. So another challenge for countries. Then I think also we'll just take another comment from Zambia online or question, and then we'll come back to the panel. So Mwango from Zambia.
Yes.
Mwango
yes. Thank you so much. I think my contribution is that I think it's high time we took it to the next level, to the World Health Assembly, because I look at it from our perspective, for the politicians to really accept the role of health information in a system strengthening of the health sector. There is need actually to show them from that assembly so that it can come down also to the regional offices or country levels. I'll take an example of institutionalization of public health informatics, for example, or NSS curriculum relating to health information system. You tend to see that politicians may not really appreciate the importance of institutionalizing this course in a particular field. But if it comes from there as the World Health Assembly, where we share the need for this investment in the health information system, I think it will really play a very important role. Also, a classic example that I can give is that in the area of GIS, many may not appreciate at the lower levels, the local MPs, but if the Honorable Minister is availed with information on the importance or the powerful tools such as the GIS in the DHRS, where one is able to analyze particular conditions in their constituency or in their ward, I think then we'll be able to see investment and also a force from the politicians to see that enough resources also is allocated in the area of health information system. I think if we do that, the making a huge contribution and later leading to improvement in the health information space. Thank you.
Thank you very much. Sorry, we had a little difficulty understanding you, but if you want to just, in any case, send your comment in writing so that we're sure that we captured it all, that would be really helpful. Thank you, Mwango. So we're going to move to the Global Fund. Go ahead with your comment or question.
Great, thanks. Mark Landry, Global Fund. Kirsten, we've had this conversation before, and I just want to get down to the nuts and bolts. WHO, Transform Health, the HDC cannot sponsor a resolution. It has to be from the countries themselves. As former WHO, I know that's the pathway. So I'm wondering whether it's the countries like Maldives, Sri Lanka, India doing this event with you. Is it governments in this room? Are there others that can be motivated to put that forward? And I'd like to know where maybe some discussions might be from the panel around that. And secondly, what are some of the specific commitments and or key actions that member states of the WHO are thinking about clarifying as part of that resolution that they would want to take ownership of? Typically, these turn out as a resolution, and then there's a way to operationalize that, calling for actions by the countries, their member states, by WHO itself, and then by partners, which fits into what the HDC is all about. So I'm wondering where are you with finding those sponsorship countries, and then what are some of the tenets you mentioned earlier, a regulatory framework, but maybe there's other things. Very curious about that. Thanks.
Thank you. Yes, at the back of the room, and then we'll come back to the panel.
Yeah, thank you. I also want to add my voice to accepting the next steps that have been presented with regard to the Global Health Data Governance Framework ending up at the World Health Assembly, as well as the next steps for moving the Health Information System Strengthening Agenda. But with regard to the Global Health Data Governance Framework, I think we've lined up several events leading up to the World Health Assembly. I think I would like to request that there is more inclusive and meaningful participation of countries in those various events, so that by the time it's getting to the World Health Assembly, there is already a general consensus. It's just formalizing it in terms of passing the resolutions. But I think also if resources would allow, it would be important that we have further consultations at probably country level. If it can be done in video countries, of course, it wouldn't be possible. But regional blocks of countries, so they are brought together. There is consultation, you get their views. So we generate sufficient consensus. So by the time we're getting to the World Health Assembly, it's really agreeing on these resolutions. And I think the importance of that is also that it is these very countries who should be able to understand, appreciate this framework, since they will be the ones that will operationalize and implement them in their various countries, and not necessarily the ministers of health who will be at the assembly and passing on these resolutions. With regard to the health information system, next steps, I'm glad to see that we have a component of country focus, but I'll again want to request that we have really focusing on countries based on need, and as much as possible, trying to address those that are lagging much behind. So there's some kind of differentiated approach whereby countries with most need are given the most support and are engaged much more. So we all come at least towards the same level and move towards a target of having all our health information systems well functioning. Thank you.
Thank you. Was there another comment from South Sudan? Others will move to Vikas. Oh, yes, you did. Okay, please take it as you're at the table.
Yeah, thank you. And as already emphasized by my colleague, we really appreciate the points that have been outlined as the next step. However, I can really emphasize or echo what was said by CDC. In the interest of trying to make it more practical and agree on concrete steps, over the last 2 days, we have reflected on what is happening at the country level. And I really appreciate the fact that the Global Health Initiative partners do really need to listen to the countries. We will not move an inch if there is no any effective engagement and collaboration that happens at the country level. We have talked about the investment, we have talked about the challenges that are related to the resources. But if we also look at it critically, there are already a lot of resources that are coming into the countries. Despite the fact that many countries might not be investing adequately in health information system monitoring and evaluation, but even what is coming from the partners, if we really follow the principle of having, one monitoring framework and ensuring integration, harmonizing the structures and approaches, we can definitely be more efficient. We can really make bigger impact and more progress in actually moving forward. I can give an example of if you could see multiple partners might be supporting an intervention, and definitely each will have its own monitoring and evaluation. You will also see, the approach or the structures that are being established with a lot of duplication here and there. And that by itself is also draining and resulting in a lot of wastage in terms of resources. The other point, which is also on the WHO side, and I like the idea of focus on the countries as mentioned by my colleague. We need to be equitably supporting the countries, and I would like also to say the context plays much role here, because we have heard from many countries. We have seen that countries are at different levels when it comes to the data governance and investment level, but we could still see there are some that are extremely strained by what is happening at the country level. So that is really key. And to conclude, I had wanted yesterday to pose a very common question. When we are talking about the data, we talk about the data governance, we talk about investment in the data and all this, and we have multiple actors, being partners, the donors, and the governments. A fundamental question must always come up. Who owns the data? Who owns the data? And we must recognize this. Definitely, the data is owned by the government. It's owned by the country. And if that is what we put in the center, I totally understand what was brought up yesterday on, let the government be in the driving seat. It's perfect. However, we also need to support the government, all right, to be in the driving seat. There are a lot of challenges. We all know when you are driving, you might have a number of passengers. They might not be seeing, they might be experiencing what you experience while driving. So it would also be good for us to echo and emphasize the need to follow the principles. Thank you.
Thank you very much. So Vikas and then Claire. Oh, okay.
Thank you. I have a mic. So I think on the sort of a broader issue of data governance, I really liked your point in terms of the time for acting on it is now. So in the next year, you don't have to wait for the resolution, but if the resolution is when things have been taken care of. So it's more of an approval. So we need to start implementing and acting on it right now, and improving things at the country level. And what it may require is the development of the framework and what all sort of needs to come together to make it happen. But at the same time, I think since yesterday and even today's presentation around the RHIS investment, it's kind of, there are a couple of other things that have also come up. So just putting some thoughts together, like every country should have a value proposition, right? That the minister, the finance minister can look and say, yes, why do we need to invest in better data systems, and what the return will come in terms of, even if not dollar amount, but in terms of life saved, right? How many maternal deaths are we proposing to be saved? How many more children are we saying will be immunized if we have better data systems? So that value proposition should be available in each country, in every ministry, so we can really advocate to the higher level, to the leadership with that. I kind of building up on other point that Malar said, that every country should have the architecture, that how these different data systems, what is the requirement, how will they be developed, who's developing that. So if there's a new project in country, the governments can say, hey, this is our need, this is the architecture, we want you to invest here, and this is the focus of capacity building. And so that architecture should be in place, that is defined by the country, that is defined by the ministries of health. And to support that sort of implementation of the architecture, we need a proper digital and data strategy that is costed and covers the full spectrum of from collection to use. We cannot have, I have seen in countries where the health information system strategy it has been years when it's not updated, because e-health strategies started coming up, digital health strategies started coming up, and it's kind of sort of lost in there. But if we can have comprehensive digital and data strategies that do focus both on digital as well as data aspect, that is costed, I think that will be helpful. And I was also talking to Anne that maybe the score is a great tool. We may need to add some minor updates in terms of capturing some indicative digital indicators to that, so it becomes more comprehensive. So we can really start to, again, measure digital and data sort of, together and not separately. And I think, this is, this group, just in the room, we have almost about 800 years of experience, right? I'm not counting you, Zen. Yeah. So we should learn from that 800 years of experience, and really see what changes do we want in the next year and how we can bring those changes together. So thank you.
Thank you, Vikas. We're going to move to Claire, who I think has to go to the airport, right? Yeah. Thank you. Yes, I have to leave at lunchtime. So first of all, most importantly, thank you all for a really fantastic day and a half. Really enjoyed it and loved meeting you all. Two things I wanted to say just in terms of this conversation. First, it's really exciting, and I'm hugely supportive of the suggestion of making sure that we get the data governance, data financing, and the connection between those things very firmly embedded in the World Health Assembly and the other opportunities coming up within the health sector, and absolutely offer to, as Craig already knows, offer to the Health Data Collaborative and all of you the support and of the global partnership in doing that, and we'll absolutely continue to be very enthusiastically involved as this proceeds. But secondly, both at the global level and at the country level, while obviously there are some dimensions of this which are and need to be specific to the health sector, and there are some important policy and prioritization questions which are within the health sector and need to remain that. Let's not miss every opportunity that we have for making connections across sectors. And I think particularly at the national level, There were some really great comments earlier about national level advocacy and the need to really present a sort of coherent case to ministries of finance and others, and comments just made about a data and digital strategy. You know, there are lots of different ministries that will have an interest in this and intersecting interests. You know, a CRVS system is critical to health. It's pretty useful for the Ministry of Education to know how many children are being born so they can anticipate demand for schools. You know, in the same way, all of the efforts that are going in, you know, led by UNICEF to connect schools via the GIGA project, pretty useful in terms of thinking about overcoming some of the challenges for district health recording and so on. So there's all kinds of connections that can usefully be made across sectors. And of course, as all of you know, because you do it better than I, you know, when you walk into the Ministry of Finance, the more unified the different sectors are around the need for this and a common set of priorities, then just strategically, the more likely we are to see success. So just, you know, I think this is absolutely a discussion that, you know, is specific to health, but we mustn't miss any opportunity to see connections between the sectors, because that's going to strengthen the case and improve the outcome, because particularly in things like governance, for example, we need to think about common frameworks that apply across sectors. So we're absolutely ready to support and offer any kind of assistance that we can, and really looking forward to working with you all on this. Thanks. Thank you so much. Can you just pass to Mathilde? Sorry, she wanted to, follow up. All right. Okay, well, meanwhile, all right. Sorry. Okay. Thank you.
I have a very quick comment. I just wanted to follow up kind of on what Craig said earlier around the kind of opportunity that we have at the moment, the political momentum, but then also kind of respond to what Mark said around, you know, the engagement of member states and the ownership by member states. I think there is a lot of momentum at the moment. I think we've also seen in our engagement with member states that they you know, maybe not the ones in the room, apart from Cameroon, who we've engaged with quite a lot as Transform Health, but there is a lot of member states that are saying we're really interested in taking forward a health data governance framework. But what does that look like? There's a lot of questions. And so my question to the panel perhaps is, in order for us to develop or to position or table a resolution at the WHA in 2024, we do need some kind of draft or a draft framework, and then also a draft resolution that gets tabled. But in order for that to happen, how do we mandate whoever is mandated to take that forward, whether it's the WHO, it's the HDC, what do you need from, you know, member states or from, I don't know, the wider community in order to get that mandate and your leadership also behind that agenda?
Thank you very much. And just to follow up, we have Mwanga Mutale. He's actually summarized his point, which we had some difficulty hearing. He says, I think it's important to escalate these discussions to the World Health Assembly to attract buy-in by the ministers of health. By so doing, I think it will facilitate and push governments to invest more in HIS. And then we had a follow-up comment. Sorry if I can find it. Oops. Well, problem with technology even in Switzerland. Okay, saying currently here in Zambia, one really needs to explain or to justify to the minister why monitoring and evaluation should continue to be a directorate and not just a unit, and why should M&E increase to its budget allocations. But by sharing with the WHO, it might mean more investment. So obviously every country has its own structure, but clearly there is, at least online, some comment on this. Are there any more comments in the room before we move back to the panel for concluding notes? No? Great. Okay.
Yeah. Great. So really great feedback, really great questions. And I think it's exactly this kind of questions we need to be asking. I want to start just by saying, kind of in the proposal we put forward, why WHA and why a resolution, just to frame, because, you know, these things could happen outside of that process. But I think why we think it is so important for it to be WHA and why a resolution, because that's where this needs to be driven by governments, as we've all agreed. And it's through the WHA process and through a resolution that governments come together, ministers of health come together to agree on these important policies. So that's why, and where it can build that kind of alignment and consensus around what those minimum common standards are and look like. So that's why we're pushing for WHA, why a resolution. 100%, Mark. We're not proposing it's Transform Health. It needs to, or other actors for that matter, because exactly, World Health Assembly is a member state convening. So it needs to be absolutely led, driven, owned, championed by governments. And so this is a bit more of a flipping the question to, you know, are there governments there? There are a lot of governments, as Matilda already said, that have shown a lot of interest, really keen to move this agenda forward, really keen to engage and help champion this, but also building on that, then are there other governments out there that recognize the importance of this and would want to kind of champion that process and a potential future resolution? Picking up on what Vika said as well, it needs to happen now, and actually also South Sudan as well. It needs to happen now. It's not about, the process needs to start now so that there is something to take to the World Health Assembly next year. It needs to be very inclusive, going back to driven by governments. It's not about handing something to governments to endorse, but really governments championing and leading that process. And then where WHO or the Health Data Collaborative or other partners, whoever they might be, come in, is more to really support and work with governments to help facilitate that process. So to help support with organizing those convenings that can bring together governments and other stakeholders to get those inputs and perspectives of what should go into a global framework, for example, but really to support that process on behalf of and working with governments, but need also for that to kick off. So absolutely the work needs to kick off now and hopefully will kick off now, but for that to happen, need the governments to also make that call and make that request to WHO or through the World Health Assembly this year to call for, you know, or to mandate WHO and other partners to help lead that process. But it needs to come from governments.
Thank you very much. And just if there's any last couple of comments from World Bank or CDC, and then we'll just let you wrap up, Craig. Is that all right?
So maybe I make 2 points. Kirsten's already covered a lot on the WHA process. The first is absolutely, I just want to pick up where you left off. It has to be a country-led process, because to your point, we want to listen to what your priorities are and how you want to drive this. So the momentum has to come now from the countries. And I sincerely hope that does come. And I think we all as partners, at least at the World Bank, we're really standing by to see how to help these investments, to drive more investments along with our own lending, financing. We've also just most recently created a new trust fund called Global Data Facility to help complement the lending investments, but also help design these investments in a way that we're investing in integrated data systems. And the second point that I wanted to make is, again, going back to, I think the resolution in WHA is important around health data governance, but it's really important to also have this international governance or global governance more broadly around data governance, not just focused on one sector. I think there's a lot of value in that integrated approach. I think, Claire, you talked about it, Vikas talked about it, and Steve, you're working on pushing this sort of this global data governance. So I think that also needs to kind of pick up pace. So it's all integrated, because you also have to look at effective investments. And there's a lot of overlaps when we talk about digital data strategies at the national level. This is also, again, a plea to the countries to think about it, to also coordinate across sectors, also at a sort of at a government level, to see how you can connect all of these agendas.
Thank you. Just a couple of additional comments. Thank you for I think most of the comments in the room I agree with. But I guess I want to address the question. Now is the time for both further action, bolder action, for a variety of reasons. You know, the attention on data issues and the problems with it, while COVID is rapidly, thankfully, fading, that did bring attention to some issues and some money beside it. And I don't think we want to lose the momentum for that. Second, the technology changes that have been made over the last 10, 15 years are really quite tremendous. And I think we should be able to take advantage of that to rethink how we think about data systems, what the tools are, how to consolidate better, how to be better organized, how to be more efficient with resources. I also think if you look at there's been a lot of talk about disharmony and competition against donors, but if you look at the digital strategies that have come out across the world, there really is a lot of commonality, mostly agreement about what the right strategic approach and designs are. So we need to take advantage of that. And then finally, I wanted to just underscore the cost of the return on investment analysis that suggested that improvements in data are comparable to the effectiveness of vaccines. I think I will, I heard one of my CDC colleagues that's heading our new Center for Forecasting and Outbreak Analytics say, better data is the next vaccine.
Thank you. Okay, Craig, if you could just wrap up and then we're going to lunch. Thank you.
Sure. I think we've got our new strap line, data is the new vaccine. That will kind of, if someone can tweet that would be great. So I've got three main things to say, and just listening over the last day and a half before we kind of break for lunch and we go into the partner roundtable. So in the afternoon, remember, we're going to be listening to, I think, 15 partners, and it's important to kind of get their perspective. But before we do, my 3 points just from listening to much of what's gone on is there are many technicians in the room, and they need valued and they need respected. But just as much of that, we need good linkages to the political landscape and the issues beyond health. So the linkage with politics and the linkage with what we're trying to do with advocacy, we all need to kind of work together, making those links between the technicians and the technical work, and the political momentum is really important beyond health, as we've heard. And that would be my kind of #1 message. We need to kind of work together on that. The second is being absolutely clear on WHO's role as a secretariat. We need to be absolutely clear. WHO is a member state organization. We are driven by the needs of our member states, specifically the ministers of health, who are obviously meeting in the next week. They'll meet again next May. But also, as our colleague from South Sudan reminded us, there's a regional committee meeting, usually in the Q3 and Q4, where at regional level, all the ministers come together at regional level to look at their priorities. We as a secretariat cannot actively advocate or lobby. We listen actively, and our different groups within the secretariat listen to member states' needs and listen to non-state actors as well. So it's being driven by your needs. But we as a secretariat, we facilitate, we convene, and we set norms and standards. I want to be clear, and I think we're reminded by our Global Fund colleague as well, just on the roles and responsibilities. So we rely on member states to really drive the agenda. We are a secretariat, we help facilitate. I want to make that clear. I think there's a call for inclusion, and I think the inclusion can help, we can help facilitate the inclusion and include more countries as you guided by you. Personally, I think there's a need for more member states from small island nations, for example, and fragile contexts, where the issue of data is not straightforward. They're difficult, as we heard from our South Sudanese colleagues. There are other member states we need to reach out and include as well, perhaps where the most vulnerable populations in the world live. I mentioned fragile contexts. I didn't mention yesterday the issue of refugees and displaced populations. And those are the exact types of populations that are going to be left behind in the 2030 agenda. I think the last thing I wanted to mention was really the issue of partnership and coming together. And aligning our efforts, whether it's through the Health Data Collaborative, and it's for you, it's your collaborative. What we're trying to do is align our efforts, our messages, and our technical, financial, and political resources around the needs of countries at a time that's convenient for them, in a way that's convenient for them, and aligning with budget cycles and planning cycles, as I've said before. And I personally sound like a dinosaur if it's like 20 years ago, but in the days of the IHP, the International Health Partnership Plus, and the range of work that went on 15, 20 years ago on aid effectiveness and alignment, that may be out of fashion now, but the buzzword was one plan, one monitoring framework, and one fiduciary framework. And that is clearly 20 years later, what we're hearing again and again for countries. So in a partnership way, using whatever platform is convenient for you, we would like to encourage everyone to align resources, whatever they may be, with country colleagues' needs moving forward. And we have an action plan. I think Vikas suggested the formulation of strategies, which are important, but again, from a personal perspective, that may be a delay tactic. It takes ages to write strategies, and it might be. So I'm not devaluing the issue of strategic thinking. It's important, but the time for actions I think we've heard is now. We need to capture this political momentum and a group of, I think, like-minded countries and like-minded partners together. So thanks for all your thoughts in the last 1.5 days. I'm going to hand back to Samantha, who's going to, I think, break for lunch and ring her cowbell.
Okay, ringing the cowbell. So remember, folks, big applause for the fabulous panel. And also, as you know, we will not get served until everyone is seated. So a nice joint team effort. Please, can we head down to the cafeteria and then we can all eat lunch and then come back for a fabulous closing panel. Thank you.
The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information system,
Hello, everyone. Please, can we head down? Because otherwise we won't get fed. Guys, hello. We need to go down to eat or no one will get any food. Everyone has to be sitting. Merci de vous diriger là pour manger parce que sinon personne ne sera servi. On est tous servis au même moment. Merci. We need to go down. Sorry.
And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities.
Voila.
And contributes to
Do
health
we have
information
Botswana?
systems that are clear, concise, and accurate.
You don't like him, Tashi. Okay, so just so it's clear, she punished us, not me.
Learn more and join us.
Okay. Hello. Do we have Oleana? Oh, great. Sorry. Hi. Sorry. Okay, so you're going to start. Great. Okay, everyone, welcome back. So I hope you all had a good lunch and have coffee. So we have an exciting panel coming up. Now we're going to hear from the partners and then countries, and you all can ask questions. So we're going to start with Oleana Seto Kokwe, who's the Deputy Permanent Secretary of Health Policy and Monitoring Evaluation and Quality Assurance, Botswana Ministry of Health, and co-chair of the HDC. Thank you, Oleana. Onalena, sorry.
Onalena. Good afternoon.
Okay, good. Since yesterday, we have heard quite a lot from countries. They have, next slide. They have actually, or can I use this? Is it working?
Press a little bit.
Okay. It has gone too far, I think. Yeah. There. Okay. We have heard quite a lot from countries that are represented here. And I think from the discussions, I think they represent all the countries that are not even here. The countries mentioned their successes. They also mentioned their challenges and also indicated the priorities that they would like the partners to focus on. So in this short presentation that I'm making on behalf of the countries, I'm making a summary of summaries from what has been discussed over the past 2 days. And we are saying if our partners or if our donors can forget all what we discussed in the past 2 days, can they please remember the 3 areas that we are going to touch today? So in terms of the areas, leadership and governance for health information systems, we realized as countries that in a number of countries, the structures responsible for health information system monitoring and evaluation, they exist in the countries. And there's also existence of health sector strategies and plans and policies and frameworks that can actually guide monitoring, that can actually guide health information systems and monitoring and evaluation. However, we also noted the challenges that are still in the legislative frameworks, especially around data sharing across countries, issues of data security. So what we require as countries from our donors and partners is to align the support that we get with country priorities. So we are saying the strategies are there, the plans are there. We need our partners to follow the one plan approach. We are also saying, since the structures are there and the country leadership is there, we would really love to have our partners acknowledge that these structures exist and support the countries to take leadership and control. So let us support our countries to be on the driving seat. That is very, very important. It was echoed by quite a number of countries. We also need support for a single monitoring and evaluation framework and collaborative use of data as well. We still need a lot of support in terms of developing in-country governance, data governance frameworks, and also to be assisted to adapt whatever global frameworks exist so that we have the country perspective in our frameworks. And then I think it skipped. What do I do to go back? Okay. Then in terms of, okay. In terms of the information, in terms of the health information system resources, particularly on the infrastructure, system and technologies, most of the countries reported that they are using some form of a system. Many of them are using DHIS2, and we had one country that was going to DHIS 1.4. So there are some forms of electronic national electronic systems that exist. However, we also heard that there are other parallel systems that have been introduced for whatever reasons. So fragmenting the information system and causing duplications in the issues of data collection and management. Other countries are still predominantly paper-based. So the ask from the countries here is that our partners should not establish parallel systems. They should subscribe to the systems that exist in countries. And they should also fund the development of comprehensive and integrated systems to improve efficiency in data management. So there should be funding that is supporting development of information systems that are comprehensive. And then the last one, which is also very, very big, is the human resource for health information system. Countries indicated that they use their health workers for collection and management of health data. However, the workers, they lack data management and analysis skills. And in a number of cases, the workers are inadequate in numbers to be able to carry out the data management activities. So what we are asking as countries here is for our donors to support capacity building at different levels. At the subnational level, we are looking at the data collection skills, the data management and analysis skills in the form of maybe the trainer of trainers who can now go down and train even at the lowest level at the clinics and so forth. But we still need that funding and capacity building. Then at national level, there are two levels. At the national level, we've got technical people who are responsible for data analysis at that level and also promoting data use by writing reports and sharing. So we need skills on data analytics, reporting, and promoting data use. But still at the national level, we have this other very critical layer of people who are leading and managing health systems. These people need to be capacitated to be able to make data a very important component of what they do, because they need to make data-driven decisions. So they really need to be supported to do that. Somebody mentioned the decision space for our leaders. So we really need to make sure that they have the capacity to be able to use the data to improve health systems. In terms of sustainability, it was also mentioned, we also need to look at the pre-service level, where we are integrating data science concepts and skills in pre-service curricula. So that is also very, very important. Another component is the technical assistance that is so commonly used by a lot of our donor community. However, we want to say this technical assistance should be related to skills transfer. A lot of times we find donors coming in with technical assistance, but there's no local partner who is actually benefiting from the skills. So at the end of the assistance, there's really nothing on the ground to show. And then for those with an inadequate number of human resources, we still ask for budgetary support for additional human resources. We thank you.
Thank you so much, Anna-Lena. That was excellent. Right, now we're going to move to Henrik Schmitz from WHO. Thank you.
I think I'll also go over here. Yeah, good afternoon, everyone, and I'll build on the intervention just from Botswana to present you a little bit a tool, a platform you have at your disposal to help drive some of this work, improving the support provided to governments to help them accelerate SDG progress. As you all know, I mean, we're at the halfway mark. The world is off track. Nearly every country is off track achieving the goals, and we need now to basically apply what we learned over the last years and really help get better in collaborating to drive progress. And many of you might know already the SDG 3 Global Action Plan. It's basically a collaboration bringing together 13 multilateral agencies active in health, convened by WHO, which provides the Secretariat also, but then many of the actors which are here in the room, from Gavi, Global Fund, World Bank, of course, key partners here in FPA, the UN agencies. And we just launched our 2023 progress report last week on the sidelines of the UHC high-level meeting. And it's an initiative which goes back 4 years to 2019, when the world convened the last SDG summit in New York, and the first UHC high-level meeting, with the idea of strengthening collaboration to help countries achieve better health outcomes. And of course, data is a key area in that, and the Global Action Plan has 7 so-called accelerator areas, data and digital health being one of them. This work is being led here also by the team, which provides the HDC Secretariat, Craig and Menya, together with colleagues at UNFPA. And there was this decision 2 years ago to really bring these 2 tracks, the HDC and this multilateral support, together. So I'm sharing a few of these insights from our collaboration, because they might be quite relevant also for the space of the health data collaborative, and we might have a few tools at your disposal which can be used. I already mentioned midpoint time to the SDGs to 2030. And we're basically developing or have extracted 6 recommendations to help us better drive progress for the second half of the SDG period. And this is based on an honest reflection of the agencies, what worked. We identified 3 areas which worked, 3 areas which didn't work, and 6 recommendations overall. So on the first element, what worked is the development of an improvement cycle on health, which can be used across countries to continuously improve the support provided by the multilateral agencies and other partners. Bilateral partners often playing a key role. Provide structures for collaboration in addition to the work on data digital health, which comes together with HDC. There's, for example, an accelerator on primary health care and on sustainable financing for health, always led by a different set of these agencies. And then, of course, we've piloted the approaches at country level, documented them through case studies, and I think we have a number of case studies on Nepal available, and Nepal has been key country leading on Pakistan, and Pakistan has been very strong, Malawi, just to name a few, and we have them all on the website because they are really meant to capture sort of the added value of this closer collaboration. And that feeds then into this improvement cycle where we rolled out 1.5 years ago, collected data over the last year, basically feedback from governments on how well the agencies are collaborating, and how well they're aligning with national priorities. That leads to this heat map, but this comes also with a set of more detailed qualitative recommendations on what can be improved, basically providing a starting point for conversations at country level on how to address some of these elements. Feedback usually provided from the directors of policy planning at the ministries of health in the countries. And the key idea here is to change a little bit the way the power dynamics and strengthening the voice of governments. We know that often the agencies rate governments in how they're doing, and sort of putting it the other way around, also in inviting governments to provide that feedback. And that leads then into can lead into joint action. We have within WHO allocated some small catalytic funds to country offices to help move some of this joint work forward and then documenting progress through case studies. So far, over 67 countries engaged, but not always with the same level of detail. Sometimes it's very focused on one of the accelerator areas. Sometimes it's a broader set of work streams coming together, strengthening primary health care, putting the financing behind it, and of course using data. Won't stay too long on the recommendations going forward, but recommendations to scale basically what worked is where we're planning to roll out the next round of this country questionnaires to get more feedback. We'll reach out to the countries there, continue documenting progress made and also difficulties through case studies. And if there's an interest to showcase some of the work you're doing, please reach out. Then, of course, keeping the structures of collaboration, the collaboration of the data digital accelerator with the health data collaborative, and then continuing to work at country level and use what we learned in some of the countries, and the missions to Malawi and Nepal provide examples there, really to scale that across other countries, because we know we need to get out of this piloting mode. Of course, over the last years, capacities to think in terms of SDGs were a bit more limited, but now is really the moment to rescue the SDG agenda as the UN Secretary General highlighted. On the three things which didn't work is one, this consistent translation to the country level. Civil society engagement has been a weakness, and we restarted a dialogue there also last week on the sidelines of the multi-stakeholder hearings. And then, of course, we're all struggling, and I think that's for the work of the Health Data Collaborative as well, with the incentives at play in the global health structure. Given the fact that each of these 13 agencies has their own governing bodies, own ways of mobilizing financing, then we have many bilateral actors that often makes it challenging to bring the processes together. And I think key learning here, and it's not a new learning, IHP plus learned the same lesson. We need a lot of political leadership from countries, really requesting a different way of working. And I think this year's UHC high-level meeting and the SDG summit really provide excellent opportunities to highlight that as well, and move us slowly but steadily to a more aligned, more collaborative way of working across the system. And with that, and sort of the assessment of the Director General, I'll close that presentation and look forward to your insights. In a way, what he highlights here as the key aspect is that we need to listen more to countries and adapt to what countries are telling us in how to improve our collaboration, because the SDGs, of course, is primarily a national agenda, and the system needs to get behind the countries to achieve that. Thanks.
Thank you very much, Henrik. That was brilliant. All right. So now everyone online, we hope you're still there, because we're going to need your input in a little bit. So the next panel session is where we're going to hear from partners what they commit to and how. So we should have on the screen the questions that they're going to be asking, that they're going to be answering. But to summarize, it is, what is your comparative advantage? What do you think of SCORE for strengthening health in HIS? And what are your priority countries for the next 2 years? So without further ado, we're going to start with a couple of our online participants. We have from Canada, Marnie Davidson, who's the Senior Health Specialist of the Canadian government. Marnie, are you online? Go ahead. Marnie? Do we have Marnie?
Yes, hi, thank you.
Hi, sorry.
Sorry, I wasn't necessarily prepared to speak as a panelist to this, but I can talk a little bit about the Canadian government's approach to how we've looked at strengthening country information systems. and then the importance of standardized tools to support those efforts. So to date, we've really looked at ensuring that all our investments in health do allow for or encourage the use of health information systems in our programming. So we've created within our own accountabilities, relying on country level health information systems to support how we collect data within our global health investments. So I think I would just start with that. And then we've also made significant investments into civil registries and vital statistics over the past years at country level, and continue to work with a variety of different partners in supporting those national systems.
Thank you. Great. So also please, when you're answering, please remember to, if you can, mention which countries would be also your priorities. Thank you so much. So we're going to move to the Data for Health Initiative Bloomberg Philanthropies, also in line, and it's Jennifer Ellis from the Public Health team. Thank you. Jennifer.
Thank you so much. It's a pleasure to be here. Sorry I can't be there in person. With respect to the pieces that you asked us to comment on, I think the comparative advantage that the Data for Health Initiative support has offered is a partnership directly with low and middle income countries around the world. The priority countries that we focus on there are 25 of them. Sorry, I'm skipping to the third answer, but the priority countries that we have had partnerships with are in every region of the world. There are 25 of them, so I think I won't take the time to name them, but they are publicly available, and we can make them available to anyone as a follow-up. The advantage that we aim to offer is creating a partnership so that the civil registration and vital statistics systems and the support for the use of data to inform policymaking are country-driven, are formulated, the priorities are formulated jointly, primarily by the country with the support, technical support of our international partners. And our reason for approaching it that way is specifically tied to something that is a major focus of the initiative, which is creating concrete and actionable and, most importantly, sustainable change in these systems, so that we are a donor who can provide support for change, but for change that can outlast our commitment to the topic area, such that when we no longer have funding in this area, the impacts are withstanding. The country capacity, I think that you asked about, is a really critical part of how we think about this work. We are able to support countries really at any level of existing health information system, and we have had very successful partnerships since 2015 with countries that have very little in the way of existing systems and have made significant improvements to those systems that continue to be sustained. And we have also partnered with countries that have relatively advanced systems that want to see improvements in some of the pieces that we know are critical, even in relatively high functioning systems, improvements to cause of death data, et cetera, that are so critical and sometimes remain gaps even in countries that have fairly advanced systems. I'll just end by saying that the SCORE framework, which we funded through the Data for Health Initiative, I commented on that in a video for yesterday's session. Our hope is that the SCORE framework really helps to specify and concretize what the various components of health information systems are that are in need of attention by countries, and how each country can understand their system using this international framework, so that it's hopefully shed some new light on where gaps might exist, and most importantly, to provide technical tools that can help to create some momentum to closing those gaps and ensuring that countries have tools to catalyze the interest that I think the